Alumni Association, and the Scientific Planning Committee, it is my honor and pleasure to invite all of you for this Advanced Medical Seminar. Our objectives are twofold. Number one, to honor the legacy, the life, and contributions of a great teacher. And the best way to honor a teacher is to teach, is to educate, and show the next generation what they can do to change the lives of patients and people. The second objective is to support a scholarship, which we will talk about later on. I think Amlesh will give you more introduction on that. Interestingly, and I didn't know this until just as of yesterday, according to the Hindu calendar, today is also an interesting special day. It is Mahalaya Amavasya, which is a special day to offer our gratitude for all previous generations, our elders, who have contributed to our life and to honor their respective legacies. So this couldn't have been planned better than to really honor a great legend in our lifetime, my dad. We are very fortunate because we have an outstanding scientific program put together. There are really terrific speakers who have spent a lot of time in putting their thoughts together, and we're bringing the best of science that's available across the world to you in the next 6 hours of this program. So at the outset, I would like to thank all the speakers and the chairpersons who will be coming after me for being here, for chairing the sessions, and especially the speakers for their hard work and delivering what I will expect will be an outstanding lecture. I would like to especially thank Professor Srinath Reddy, who will be coming a little later on, for I'll actually say this right away. When I emailed him almost like 9 months ago, I think the email reached him something like 11:30 in the night, and within 30 minutes, he responded to me, which must be midnight in Delhi, saying that this is something I'm most proud of doing it, and the best way that I can honor and respect my teacher. I still remember those words in his email, and I'm grateful to him for being here amongst us, and we will learn more about Professor Srinath Reddy later. Now, for those of you who are interested in using the restrooms, there is one, I believe, 1 floor above outside. You can go 1 floor up. And there is one next to the elevators. And for those who can use this front door, you can go through there, or the back door, and you can use the cloakroom. Now, please switch off your cell phones now. We do not want disturbing the speakers and other people who are listening, or you can put that in vibration mode. So please take your cell phones and put them in the vibration mode. And I'd like to take this opportunity to welcome our online guests who are not physically here across America, US. I've got Dr. Arun Nair from New Zealand and so many others from different parts of the world who are participating through the live Zoom link. So thank you and welcome everybody here. The first part of this program is to honor Dr. S.R. Rao, and we will light the lamp. And so I invite Professor Srinath Reddy to please come here. He'll be our chief guest. Dr. Sabu, please join us. Sheila and Rupa, please come and join us for lighting the lamp. Thank you. So we have a representative of the family, and on behalf of OKGMA, I will do it. And then on behalf of API, Dr. Sabu, and our main oration speaker. So we'll be the 5 people who will light the lamp. We'll start with the ladies.
Gajeshanaaya Bhalachandraya
the session.
Sir, I had many occasions to take my patients to him, and my mother also was treated by him. Now, without wasting time, I would now request Dr. Rakesh Sahai. He's a professor of endocrinology, head of the department in Usmania Medical College, and he's a well-known figure in endocrinology in Hyderabad. Over to Rakesh Sahai, please.
Thank you, sir. Thank you for the kind words of introduction. I'm in memory of Professor S.R. Rao. I myself probably didn't have a direct contact with Dr. S.R. Rao, but my father worked in his unit. He was his assistant in the unit, and also Dr. K.J.R. Murthy is a very close friend of my father. Both of them were closely associated with Dr. S.R. Rao, and I used to hear about him from them. And also, when I was the secretary of the API Hyderabad chapter, so I had the good fortune of organizing the oration on during my tenure. I was the secretary for about 3 years, and during that period we were also fortunate to have Dr. Satish Rao coming as the orator for one of the orations during that period. So that is the association that I have with him, and it is indeed my honor to be speaking here today. And I would be speaking about the science of obesity, discussing about so what I would be doing in the next 20-25 minutes or so is discussing about the burden of obesity globally and in our country. What are the consequences of this problem, and the physiology of, then I'll go on to briefly discuss about the physiology of weight regulation and also the etiopathogenesis of obesity. Then discuss about the benefits of weight loss and the concept of weight regain, which is the major limiting factor in the treatment of obesity. And then briefly discuss about the current and future therapies for obesity management. As we all know, we have very little current therapy available, and we look forward to several new developments that are happening, and we are seeing that there are several new compounds that are, new treatment options that are going to on the anvil for management of obesity. So I'll be discussing briefly about that in this CME, which is discussing about futuristic medicine, looking at what is the current status and what is the future for the management of obesity. So if you look at the burden of obesity, we see that globally this is a huge problem. There is a huge epidemic of obesity, and we see that today we have almost 650 million people who are obese, and there I think 3 times the number of people are overweight. 1.9 billion people are overweight, and there are at least 2.8 million people dying because of obesity related problems. So that's the huge burden of problem across the globe. And in India too, while we think that we are still underdeveloped, but or rather a developing nation, but we find that we still have a huge burden of obesity, while we have a burden of other problems. Undernutrition is also a problem in some parts of our country, but obesity is again a huge problem with more than 135 million people who are obese. And the ICMR INDAP study, which was in 2015, reported the prevalence rates of obesity to be about 18 to 30%, and equally higher number, or maybe slightly higher number of people who are centrally obese. So they may not be obese by the standards of BMI, but they are centrally obese because they have higher abdominal fat. So this is a huge epidemic which is being increasing in the last few decades. If you look at the last 2-3 decades, track the trajectory of weight in the last 2-3 decades, we see that the problem of obesity is increasing in the last 2-3 decades. And this shows the National Health Survey, the data from the National Health Survey, which shows that the burden of obesity is quite significant in some parts of the country, at least, and Telangana comes into that red zone, which shows that we have a very high prevalence of overweight and obesity. So, having looked at the extent of the problem, or the numbers that we are dealing with, let me quickly take you through the physiology of weight regulation. In simple terms, we can say, although this is a very complicated topic, it's not as simple as I would be, depicting it, because if you put it down in simple terms, you could say that body weight is determined by the energy balance, the amount of food that is going in and the energy that is being spent out. So this is in simple terms like a bank balance. You can see what is being put in, what is coming out. So that's what in simple terms decides the weight. But there's several other aspects to it. The energy expenditure has to be, different types of energy expenditure that is there. The food intake also is regulated by several different factors. It is not just if you try to dissect out these two components, you see that the intake one is the physiological intake, or the one which is regulated by the metabolism, that is decided that is decided by the energy requirement of the individual. But then added on to that is a hedonic food appetite, that is because of the appearance of food and various other factors. And then there are psychological factors which come in, which add on to this appetite, to the food intake. So these are important components. So while the lower part, the blue part, will remain the same, but it is the orange part which is decided by the type of food that we are dealing with, and then the green part which is decided by several other factors, the psychological factors. And now we see that food intake many times is compulsive, decided by stressful eating happens, and those factors are coming in the green zone. So this is what is deciding the food intake. And if you look at the energy expenditure, we have a resting energy expenditure, which is taking care of the physiological needs of the individual, while we have but then we have the thermogenic component of energy expenditure, which is the energy expenditure to utilize the food that is taken in, that is decided by the food that is taken in. And then we have the activity induced energy expenditure, which could be again divided into two types. One is decided by the exercise that we do. We generally look into that only, but what also is there, another component which is there, is the NEAT. NEAT is the non-exercise activity thermogenesis. So somebody who is very active, compulsively active, or other than doing exercise, other than structured exercise, if a person is fidgety, active, moves around quite often, so that person has a higher NEAT, and he tends to spend more on energy in these activities, and that also decides the energy expenditure. That is an important component which often is forgotten, and that is something which has an important bearing on the weight. Now, when you come to looking at the regulation of the appetite, this is a very complex mechanism which has different components. There are different levels at which it is regulated. One is at the level of the hypothalamus. You have various peptides which are secreted from in the nervous system itself, which are having appetite stimulating effect. And then you have the anorexic factors. Anorexic factors are the ones which suppress the appetite. And then you have peripheral signals, which are again mainly from the GI tract, from various parts of the GI tract, which are regulating the appetite again. And most of them are the anorexic signals, as you can see from different parts of the gut. GLP-1, which is actually used for therapy, and then we have GIP and several other peptides which are being studied for therapeutic purposes for regulating the weight. And then you have a orexogenic peptide, the ghrelin. And if you look at the way these peptides work, they are working at the level of the hypothalamus, and they are regulating the activity of these nuclei, which are again then influencing the activity of other nuclei present in the brainstem, and these in turn regulate the appetite and also the energy expenditure that is happening. So I'll not go into too many details of this, but suffice to say that there are centers in the hypothalamus, which are the ventromedian nucleus and in the lateral hypothalamus, which are regulating the appetite through the effect of these various gut peptides, and also the neuropeptides secreted in the brain itself, and which are regulating the appetite. Now, there's a significant effect, role of the brain in controlling the appetite. We have the hedonic eating, as I was speaking, which is over and above the eating for hunger, which is decided by the type of food that is available. And then we have the various other feedback mechanisms and which are regulating this. So dopamine is one of the important signals which creates the motivation to eat. Opioids and cannabinoids are the ones which control the liking, the pleasure associated with food. So these are the ones which regulate that, and exercise, and then there are various factors which are coming in, which are these neuropeptides are secreted in response to various feelings, thoughts, and behavior, and these are all in turn affecting the appetite through their actions at the hypothalamic level. So as you can see, when you look at what causes obesity, so there is a mismatch between the energy intake and the energy expenditure, and this can be because of genetic factors which are contributing to very small number of people with obesity. But more than that, we have other factors like factors which are regulating the appetite. They are factors. The most important ones are the environmental factors. Medications can influence the appetite and the energy expenditure, and these are all the ones which are more important in the common garden variety of obesity that we are dealing with. So if you look at genetic factors, there is a high heritability of body weight also. There are genes in the hypothalamus, in the leptin melanocortin pathway, which are regulating the appetite, and single nucleotide polymorphisms or SNPs in these genes can lead to obesity. But so if you look at the number of genes that are regulating the appetite, there's so many loci which are associated with obesity traits. But and these are mainly working through regulating the total body BMI, and also the body fat distribution, and they are also these are expressed in the adipose tissue. So there are many genetic loci which can affect obesity. SNPs in these genes can cause obesity, but what we need to understand is that when you compare monogenic versus polygenic obesity is the common variety of obesity that we are seeing. The monogenic obesity is seen very, very rarely in younger individuals at early age, and you can see that it has a large genetic effect as compared to the polygenic obesity, where the environmental effect is the maximum effect. And so this is how we can differentiate between polygenic obesity versus the common variety of polygenic obesity versus the monogenic genes. This has to be dealt differently. So that is not the concern today. We are discussing more about the polygenic obesity, which is managed by environmental factors, mainly the social cultural factors, traditional beliefs and peer pressure, socioeconomic factors, and food and the environment that is available, the availability of inexpensive, highly palatable food, and the various reasons for decreasing physical activity that is happening across the globe. We are seeing that the levels of physical activity are decreasing with automation and mechanization. We are seeing that less and less physical time is being spent on physical activity. So we see that what are the consequences of obesity? Obesity leads to several metabolic problems. As we can see, it's the major driver for the epidemic of type 2 diabetes, as we all know. It is also a driver for the epidemic of cardiovascular disease, lipid abnormalities, blood hypertension. All these are regulated by the weight. And in addition to that, there are several mechanical problems that occur, like osteoarthritis, obstructive sleep apnea, and several other problems which again have an effect on the metabolic aspects. And then we have several different types of cancers which are related to obesity. So obesity has significant impact on various disorders. As you can see, this slide lists out the various problems associated with obesity, going by looking at system wise. We're saying that it's responsible for a major driver for the epidemic of non-alcoholic fatty liver disease also today, that we are seeing. Several problems in the several gallbladder disorders are caused by obesity. PCOS is a common problem associated with obesity, and there are other cancers which are associated with obesity. So, having looked at that, let us now look at some of the benefits of weight reduction. So, if you look at weight loss, it leads to significant improvement in most of these problems, as we have seen that these are driven by the epidemic of obesity. But what we need to understand is that even 5 to 10%, a modest weight loss of 5 to 10% leads to significant metabolic benefit. It leads to normalization of blood. So if you look at the efficacy of these agents, what we see is orlistat is the one which has the least efficacy because of the problems of various problems that are there, and in terms of its limited efficacy, and also the adverse effects in terms of excessive, oily stools and other things would make it difficult for it to be tolerated by most individuals. And while we have good efficacy seen with the other agents which are being used currently being used in different parts of the world, we have semaglutide and tirzepatide which are showing a good promise, because you can see the extent of weight loss that they're providing is also much better than what is seen with the currently available therapies. Now, going to the recent advances, recent therapies that are available, I think I have about 4 or 5 minutes. Oh, 1 minute. Okay. So if you look at the recent advances, you see that semaglutide is one molecule which is a GLP-1 analog. It has got long duration of action. It has got metabolic benefits, but it has also direct effects on the hypothalamic region, which controls appetite and the energy expenditure, and therefore it has been shown to have significant benefit in terms of the weight reduction. 2.4 milligrams of semaglutide has been used in the phase 3 program, and it has shown a sustained weight loss in different studies called the STEP program, which showed a good weight reduction of close to about 10 to 12 kgs. Similarly, we have a new molecule called tirzepatide, which is, so this is a categorization of weight loss. More than almost 30% of people could lose, or more than 20% could lose about 20% of their weight. So if you look at the other agents that are available, there's a favorable effect on the body composition also with the use of semaglutide, while and an acceptable safety profile. Now I'll just quickly show you some data about the newer agents which are on the anvil. As you can see, the GLP-1 analogs are the future of obesity management, as you can see, and we have been moving from the various earlier GLP-1 analogs to the combined therapies. Now we are looking at combined therapies. One of them is this tirzepatide, which was the study of tirzepatide, which was studied recently, and this was published in the NEJM, and you can see this is a combined GLP-1 GIP analog, which has complementary mechanisms of action which augment their effect on the weight reduction produced only by the GLP-1 analogs. So if you look at the weight reduction seen with tirzepatide, it was quite impressive, to the tune of about 10 to 15 kgs in this SURPASS program. As you can see, a good weight reduction about 10 kgs seen in most of in this program, and this was followed up for several years, and you could see that there was a benefit, continuing benefit with the use of tirzepatide. Similarly, we have a
Dr.
new
Rakesh,
drug called
request you to please wind up.
Yeah,
we'll have a discussion during the panel discussion.
Yeah. So I'll just conclude therapy that has to be used, and although currently there are several unmet needs, several new therapies are on the anvil, and we look forward to a good several new agents for the management of obesity. Thank you.
Genomics and the other omics and the newer insights which have led to the concept of precision medicine and heterogeneity of type 2 diabetes with the various subgroups, and the concept of precision medicine and the precision medicine versus the personalized medicine and the way forward. So if you look at the diabetes, hyperglycemia is the phenotype, that is the clinical phenotype. So behind it, so many other like genetic factors, lifestyle, environmental factors, the insulin resistance, and the pancreatic diseases, either autoimmune or the damage or the pancreatitis or the endocrine or the syndromic features, and the drugs or chemicals. Whatever may be the pathophysiological mechanism, the brunt is on the beta cell failure, causing either absolute insulin deficiency or the relative insulin deficiency, culminating into development of a hyperglycemia, which is the clinical phenotype. So this is the classification of diabetes mellitus proposed by WHO in 2019. So you can see the type 1, type 2, which we are very familiar with, right? So these are all again other specific types. And if you look at the books, so definitely these are all there. What is new is the red colored one. That is the hybrid forms of the diabetes. One is the slowly evolving latent autoimmune diabetes. To ascertain that what type of diabetes we are dealing with, so that we can plan for the management, we can predict the risk of complications, and even the cardiovascular risk also. So how are we doing that? So based on the certain parameters, clinical and the laboratory parameters, we are doing it. So what are the clinical parameters? What is the age of onset? So younger the age of onset, it's more likely to be a type 1 diabetes. Or the history of DKA, like presenting with diabetic ketoacidosis, goes more in favor of a type 1 diabetes. And the history of pain abdomen and steatorrhea is suggestive of a pancreatic pathology, either chronic pancreatitis or trauma or cystic fibrosis. And the history of drug or chemical, that notorious one is the corticosteroids, which can cause diabetes. And the family history of diabetes. This is also very important because both type 1 and type 2 have though they are polygenic, they have a heritable component. And if you look at the MODI, maturity onset of diabetes in the young, so it's like an autosomal dominant inheritance. So at least 2 or 3 generations of family history to be there. So this is the help of the family history. And the anthropometry does help us, how the BMI is, whether the patient is normal or the obese or overweight, and looking at the waist circumference. In the previous talk, we have come to know about the obesity. So waist circumference, 80 centimeters for the female, more than 80 centimeters considered to be a visceral adiposity, and for a male, more for the Asians. For the Asians, more than 90 centimeters for a male is considered to be a visceral adiposity, along with WHR, waist-hip ratio, and the body habitus, any lipodystrophy. And the insulin resistance markers. The clinically important is the insulin acanthosis nigricans, or the skin tags, which are suggestive of a underlying insulin resistance. And the autoimmune markers, like presence of a vitiligo or premature graying, or any other presence of autoimmune disorder. And the syndromic features, or the endocrine, suppose acromegaly or Cushing, they can be having a diabetes. So by all these clinical markers or clinical features, we will be able to make a diagnosis of diabetes. Then what is new? Sorry. So let us understand one case scenario, how it exemplifies the importance. So this is a 22-year, which we have seen in our Usmania. So she is a 22 years old woman. She was diagnosed with diabetes 6 years ago. That means diabetes was diagnosed at the age of 16 years. So she was young and she was started on insulin, and her mother was diabetic and she was not very compliant with the insulin treatment. She stops in between. So no history suggestive of any DKA, pain abdomen or steatorrhea. So no pancreatic pathology, no history of DKA. And on examination, BMI was 20 kg per meter square, that is normal BMI, and no evidence of any insulin resistance or the autoimmune markers, no lipodystrophy. And she was a normotensive. And labs are A1C 10%, so severe hyperglycemia. Ketones were negative, and thyroid is normal. Ultrasound also is normal. So looking at this clinical scenario, what is the diagnosis? So any PGs? So, okay. So the diagnosis, generally, most of the time, we err on the side of type 1 because a younger onset of diabetes, right? Though no history of diabetic ketoacidosis, we err on the side of type 1 diabetes, or sometimes same scenario has been discussed with our PGs. Some were saying like erring on the side of type 1, some were erring on the side of type 2 diabetes. So either we make a decision of type 1 and continue with the insulin, or we can give a trial of, this is what. We will come back to this once I discuss the some more slides. This is another scenario which we have seen in our OPD. So she was a 4-month-old girl baby. So presented with history of failure to thrive of 1 to 2 months duration, and got admitted with sudden onset of vomitings and altered sensorium. At the admission, blood sugars were very high, 546 milligrams per deciliter, and ketones were positive. So suggestive of a diabetic ketoacidosis. This was the presentation. So baby recovered after the insulin therapy and continued on insulin therapy. So what is the diagnosis? Younger the age of onset, so diabetic ketoacidosis, right? So goes more in favor of a type 1 diabetes. But if the diabetes onset is less than 6 months of age, we call it a neonatal diabetes. How we manage this case, again we will come back to it. So then, having discussed on the clinical parameters or what we are doing now for our management of patients, what is new? Let us look into the newer insights. So this is the some insights from the genetic studies. We all agree that genetics play a role in our health, right? So if you have a favorable genetic and a favorable environment, so good quality of life and good health. So if you have an unfavorable genetic profile and unfavorable environmental conditions, so there is a bad health, right? So in between these two extremes of the genetic situations or the environmental influences, we have huge variation that provides us the opportunity to change the trajectory of the individual by the self-management or the access, providing a good quality care or the providing a access to the health care. So this is the, I'm unable to, right. So genetics represents only one contributor. As we have said, there are lifestyle and the other environmental factors. So in the case one, like either it, like we have discussed, a young lady presented with like severe hyperglycemia, was on insulin, non-compliant, no history of DKA. So she was subjected for that genetic testing, and it came out to be a HNF1 alpha mutation suggestive of a MOD3. So she was off insulin and started on glibenclamide. She is doing good. And another case scenario, young girl, so baby, genetic testing was done and came out to be KCNJ11, so which is again sulfonylurea responsive. So we don't think of starting sulfonylureas for a younger girl because of the fear, right? So this is the importance of genetic testing and to choose an appropriate therapy for management of our cases. Okay. So now a little word on the pharmacogenomics. Again, there is a great research which is going on to understand the response of a particular therapy. Suppose sulfonylurea or metformin. So whether this, based on the genetic mutations, how effective for a particular individual use of metformin or the sulfonylurea are associated with any intolerance. So though there is a great research which has been done, but still the clinical translation is limited. So again, so actually metformin is it is not metabolized. There are some transporters for the metformin to be transported into the cell. So genetic polymorphisms can alter the efficacy of the metformin in a particular individual or can lead to a gastrointestinal side effects. Similar is the case with the sulfonylurea. So we will just quickly rush through that. So this is again importance of the genomics to choose a particular therapy. As we have said, like MODY, HNF1 alpha and GCK. GCK may not require any treatment, only during the pregnancy. If the baby is not affected, fetus is not affected, then we have to treat. If the baby also is affected with the same gene mutation, we need not treat. And KCNJ11, that is the neonatal diabetes, again requiring sulfonylureas. So this is the importance. So we'll quickly rush through. These are all the, again, some genetic aspects which I have kept. I think we will rush through this because of the short of time. And again, a small, I just want to introduce the terminology, insights from the omics. So what do we mean by the omics? Omics is the genomics or the mutation risk in a given individual. So what has been, this is from the Western populations. So what has been done with respect to our India? This is again from the inspired. So this is from the Mohan's diabetic centers across the country, approximately 50 centers. So this is again data-driven cluster analysis inspired study, which has again similar on the lines of the previous study. Okay, so these are all the parameters assessed. So this is, look at this, when compared to the previous cohort, so we have a little different phenotype. See, one is again severe insulin deficiency diabetes, which is similar to the Swedish population. So insulin resistance, again, which is similar to the previous population. This is a unique cohort which has been identified in our population. What is that? Combined insulin resistance and the deficiency diabetes. That means both components are there, beta cell failure as well as the insulin resistance, so that again it will help us to choose an appropriate therapy. And the mild age-related diabetes. If you look at the severe insulin deficiency diabetes phenotype, so they are like lower BMIs and even the waist circumference.
I would now request Dr. Rakesh Sahai.
Concept is there. He emphasized that more than 25 is obesity for us, whereas the Westerners is more than 30 is obesity for us. The other point which I would like to say is that people usually ask us, how much weight should I reduce, this one. 10% of their weight should be reduced. It's been shown by 2 biopsies, 50% of them, there will be reversal of the fibrosis can occur, but unfortunately only 10% can achieve this target. The last point which I would like to make is that, remember that the cancer is a malignancy. Both obesity and the diabetes, 4.5 times the risk. Only diabetes, 4 times the risk. Only obesity, 1.5 the risk. So if you look at all cancers, irrespective of this one, we are of course interested in hepatocellular carcinoma, but all cancers, the longer the diabetes and the more the obesity, the chances of malignancy are very high. And the selection of the anti-diabetic drugs with us depends upon, again, NASH, who are having NASH and diabetes is different from diabetes without any NASH. Thank you very much.
Lower cutoff because we say that we are having a problem of, metabolic problems at a lower BMI. So we say 37, whereas 35, it would be for overall, worldwide what is used. We would say 32.5, about 2.5 kg per meter square lower than the Western cutoff. And this is also decided by the presence of various target organ damage and other problems. If they are there, then probably you use a little lower cutoff than presence of diabetes, presence of other metabolic complications may need a lower cutoff to be used.
Sir, as if, how come you didn't use till now? So where do we place semaglutide in current scenario? Is it like, because recently we had a discussion on semaglutide and they say that the earliest you start, you have much benefit because it has multiple levels, the way mechanism of working. So either for weight loss or diabetes, of course the recent literature says weight loss, it has though very big advertising going on, but still it is only very minimal is what we have noticed. So your experience regarding semaglutide?
Yeah, so I think as you're mentioning about semaglutide, which is 1 milligram dose, which is the subcutaneous dose is 1 milligram for diabetes management, but that is not, again, that is not what we use.
3, 4.
We have the oral 3, 7 and 14 milligram tablets. So the 14 milligram tablets have been shown to have in the studies have been shown to be quite effective in terms of weight reduction, and almost 30 to 40% people have lost more than 5% weight with that with the use of oral semaglutide also. So it is a good medication in terms of diabetes management and also in terms of weight reduction. It may not be, as you said, for weight reduction, it may not be very helpful at that dose. You may require a higher dose for weight reduction, but that is the current status of semaglutide in India, at least.
So can we place after metformin? That's what.
Yes, in people who have indication vascular disease or presence of renal disease, and in patients who have got established atherosclerotic cardiovascular disease, use of semaglutide can be considered right after metformin. You can consider using it because there you are likely to get the maximum benefit.
Sir, what is the role of medical marijuana in obesity? Medical marijuana.
What's that?
Cannabis.
Huh?
Cannabis, sir.
Oh, well, that was you had a medication which was working through the cannabinoid receptors. Rimonabant was there in the market, but because of high risk of suicidal tendencies, it was withdrawn from the market. So I don't see any potential role for Rimonabant, but we can probably look forward to therapies which are based on the same pathway, working on the same pathway. But as on today, we do not have any medication available on that, working on that pathway.
Thank you, sir.
I think we'll, okay, sir.
Sorry. No. The role of diet, is it the only important thing in the management of obesity? Because of so much of advertisements going on you did not discuss about the role of SGLT inhibitors in controlling hyperglycemia and weight loss in the patients of diabetes.
I think next to the GLP-1 analogs, SGLT2 inhibitors are the medications which are good in terms of weight reduction, but the weight reduction is modest to the tune of about 2 to 4 kgs on the average. But there could be individuals who could lose much more with the use of SGLT2 inhibitors. And as regards the diet, I would say that the diet is the major factor. If you look at comparison between diet and exercise, it's probably the diet which is more important for weight reduction, while exercise is more important for...
Not have facilities for general investigation and on these counts. Can you comment on?
So actually that's what currently the clinical utility is limited. Clinical correlations of?
Suspecting certain types of etiology. Like you said about 4 months old baby, it has been published. Especially Dr. Nadeem Rais was one of the person who spoke a lot on.
So as I said, like sir, like with the diagnosis, with respect to diagnosis, neonatal diabetes, anything onset of diabetes less than 6 months should be subjected for genetic testing, because most often 80 to 90% of the time, like there is a genetic monogenic cause of genetic diabetes is there. So they have to be subjected, and depending on the report, like depending on the genetic defect, so we have to choose either sulfonylurea or insulin for that child.
Thank you.
Diabetes which is very mild, which is not likely to lead to complication. Over-treating them is not required. Then you have other groups which are more likely to develop complications, where we need to be more aggressive right from the beginning. So that is the benefit of doing this cluster approach, which can help us in stratifying patients based on what their treatment should be.
Yeah. Thank you, sir.
We conclude. My only observation is, for reducing obesity, it should be guided diet and guided exercise. If we do it alone, we cannot reduce our weight at all. The dietitian should be involved, and the physical therapist also should be involved if you want to reduce the obesity.
Yeah. Thank you for a wonderful session. May I now...
Or early 80s, and Satish also remember, we used to use endoscope just for diagnosis, peptic ulcer disease, cancer, and so on. This has dramatically changed now. Gastrointestinal endoscopy has become a therapeutic procedure now predominantly. It is still diagnostic, but mainly therapeutic. And this is because of the pioneers you see here in 1970s. These are the pioneers who actually were not only innovators, but endoscopists. And he did the first endoscopic splenectomy in 1974, removed common bile duct stones in a patient in Paris. 1 hour after he did this, he was called to the director's office of the hospital and told US and of course Belgium. They were responsible for teaching many new endoscopic techniques to Indians, and of course many of us went there and trained with them before we could start using these procedures. Next slide. The first therapeutic endoscopic procedure was done in 1973 and reported simultaneously by Meinhard Claassen in Germany and Kawai in Japan. Next slide, please. Actually, if you look at these first slides, I got this from Meinhard Claassen from Germany. This was a nurse working in his hospital who had a CBD stone, and they did a splenectomy. The second one shows, in Japanese, it was a Japanese doctor working in gastroenterology department who had a CBD stone, an endoscopic splenectomy done, removal of the stone. Now, in these two people you can see were people working in gastroenterology department who had this procedure done, because others were refusing to get it done. It was so experimental and new at that point of time. Slowly, of course, these procedures got more and more, widespread. So this was when I came back to Hyderabad. Again, you can see a lot of hair I had at that time. This was very long back, and at the same time, the Satish also was actually practicing for some time here. It was the type of endoscopes we had at that point of time, and you can see it was not easy to use these endoscopes. But over a period of time, technology has dramatically improved. Michel Kramer came to Hyderabad at that point of time and taught us how to do endoscopic therapy of pancreatic diseases. Next slide. And of course, the changes that have occurred is because of new techniques and technologies that have come in next. And what has happened in endoscopy now is very surprising, is that there is also become segmentation or sub-specialization. You may be surprised as physicians that we know, and I think Professor Dayasagar is also here, cardiology, same thing has happened. We have become sub-specialized even in endoscopy. There are some of us who do only pancreatic biliary endoscopy. Some of us who do only third space endoscopy. Some are doing only endoscopic ultrasound. So it's become very, very subspecialized. I don't know if it's good or bad for the patients, but the results get better as it becomes subspecialized. It's like a motor car industry where each part is produced by different people and everything is fit together at the end. So the clinical gastroenterologist actually comes at the end after the patient is treated by various of these subspecialists. Next slide. So in pancreaticobiliary endoscopy, one of the things that has happened is, like cardiologists now, we are going on to using a lot of metal stents. All these plastic stents are no longer used. They've gone into the graveyard of endoscopy. Next slide, please. So we are starting to use this. Next slide. We are starting to use these metal stents, which are commonly used for a variety of conditions: obstructive jaundice, draining pancreatic fluids. Similarly, biodegradable stents are being used, and this is the advantage of biodegradable stents. That again, they were introduced for a short period in cardiology, did not work for coronary stents, but for gastroenterology, they are much more. GI tract is generally more friendly than the cardiac tracts. So they tolerate the biodegradable stents very well. Next slide, please. So we use it for benign biliary strictures, put the stent, leave it alone. 3 months later, the duct has opened and the patient is all right. Next slide, please. So next slide, you can go to the next. These are just videos just to show you how we put in these stents through the endoscopy. We can put these stents and open it up like a balloon. Again, like a coronary stent, we open it up, leave the stent in place for a few weeks or months, and then the stricture opens up, the stents dissolve simultaneously. These are technologies which are changing the way we treat our patients. Next slide, please. Next slide. The other thing we have done is, if we had, for example, the new adjuvant therapies that are coming. If you have a patient who's to come with us, for example, cholangiocarcinoma, advanced stage, we just used to put a stent and tell him, look, lymphoma. And here you can see caseous material coming out of this in the bile duct. This turned out to be tuberculosis. Both these patients were treated adequately medically and are still alive. So just to show you real stark examples of how endoscopy is changing the diagnosis and therapy of many of these patients. Next slide, please. Next slide. Yeah, so this is, in 1989, there's a new modality of endoscopy called endoscopic ultrasound. This is a technique where to the tip of the endoscope we can attach an ultrasound, and we go inside like cardiac ultrasound is done, like transesophageal echocardiography. This is more sophisticated machine. We can go inside, see what is happening. So I went for training in 89 to Germany to see if I can learn this technique. Unfortunately, at that time, the scope, please. Next slide. I'll quickly go to next slide. This is how we do endoscopic gastrojejunostomy. So we just put the endoscope inside, and now we can connect the stomach to the jejunum or to the duodenum using this technique without surgery. The procedure takes only about half an hour to 45 minutes. The patient is often discharged an outpatient. So this is going to revolutionize and change the way we approach many of our patients. Now gastrojejunostomy is less frequently done. Endoscopic GJ is more frequent. Next slide. Next slide. Next slide. Now, laparoscopic surgeons are doing. The third space is the space between the mucosa of the gastrointestinal tract and muscularis propria, the submucosa. Now, you may wonder why so much attention to this third space, such a small space. It is not a small of achalasia cardia. That is when there is tightening of the lower esophageal sphincter. Next slide. So, in 2008, Haro Inouye did this procedure. In 2010, published this. So the procedure is called POEM, peroral endoscopic myotomy. Easy for the patients to remember, so it's termed POEM. And in achalasia cardia, are now replacing standard surgical techniques to treat these patients. Next slide, please. So that now, many of these so-called surgical procedures have become a domain of endoscopists, and you can see that there's a wide spectrum into which endoscopy is going. Next slide, please. In 2003, this is my colleague, Dr. G.B. Rao, and together we had a patient with extensive anterior wall burns, but he had acute appendicitis. We couldn't do, he couldn't do an acute appendectomy, and therefore what he did was to go in through the stomach, make an opening in the stomach through the endoscope, get the appendix out, and then see the very inflamed appendix, he took it out through the opening in the stomach. Gastroplasty is being commonly done. In our own unit, for example, almost every day we have a case where endoscopic sleeve gastroplasty is done. The stomach is reduced in size. This not only decreases satiety but sets in a lot of hormonal changes. An ultimate result is significant weight loss. Next slide, please. There are now studies which have compared endoscopy versus laparoscopy and clearly shown that endoscopy is as good. So the shift towards endoscopic sleeve gastroplasty now in many of our patients. Next slide, please. And more exciting, I think this is for the physicians, is the metabolic therapy. We used to think that the metabolism is controlled by pancreas. We know that that's not true. Metabolic process in the body is now controlled by the duodenum, D2, D3, D4. Nature has made it that such a way that the first contact with the food, this is what comes into first contact with the food. All the neuroendocrine, endoendocrine tumors are there. So can we modulate that? So in patients who have type 2 diabetes, what has been found is that in this segment of duodenum, second, third, fourth part of the duodenum, there is hyperplastic tissue, and also there is huge amount of enteroendocrine cells. And there is insulin resistant factor that very early in the gut. Next slide, please. And you can see what happens to the whole matter. By resurfacing the duodenal mucosa, you can actually decrease A1C to more than 1.5%. Even new drugs, if you can get it down to 1.5%, it's very good. So with just for duodenal mucosa resurfacing. You can also decrease the ALT, AST, the NASH. Some patients, even NASH has been reversed now. Insulin requirements have completely gone. Zero insulin is being used. And of course, the antioxidants levels increase, inflammatory levels decrease. So this is a very, very exciting field that endoscopy is entering. It's an endocrinologist field. And there are two ways looking at it. Either the gastroenterologist becomes an endocrinologist or the endocrinologist learns endoscopy in future, because this, I believe, is going to be some exciting future that's coming in. They're very early reports, and we have had some experience with this. I worked with Jack David and Erasme on this and had some very exciting experience. We are now trying to convert this energy into electroporation energy, which is very simpler to use. We have an animal lab in our hospital where we're working on this, and we have seen that very early on that you can actually ablate the mucosa completely safely using this. So every 2 years, a diabetic, type 2 diabetes has to come. We just do an endoscopy, clean the mucosa. He's okay. And then maybe after 2 years, if we're still having the lifestyle which caused this, again, hyperplasia of the duodenal mucosa, again get it done. So this is going to be a new way of how we are looking at diabetes. Next slide, please. So in addition to these new scopes, new accessories are coming in. I'll just finish this briefly. Next slide, please. Next slide, please. So what is other thing that's happening in gastroenterology is a push for single-use endoscopes. There are some infections which occurred with ERCP. So the FDA in US is pushing the companies to make this. We have the single-use endoscopes now, predominantly duodenoscopes. The costs are coming down. If the scope is going to cost $200, in US, for example, it's not very expensive to use that type of scope. In India, it's still costly. Next slide, please. So what we have now started in our department also, using in certain indications here because it's expensive. If the patient has already a multi-drug resistant organism, we don't want to transmit it from this patient to another patient. Or if you're dealing with immunocompromised patient, we use this. I'm actually doing ERCP in this case as a demonstration. There's a large CBD stone. We balloon dilate the CBD stone, and then the stone is being removed now. This is, you can see the stone is being removed. Now, once the stone is do with a single-use endoscopes, now we can. Next slide. Next slide. We have these new types of scopes called the enteroscope. This is like a car being driven. The endoscope is driven by a power spiral car. You just put it in the mouth. It keeps on going by itself. It goes through the whole small intestine. We can now do in 95% of the cases pan-enteroscopy, which was not possible with the earlier scopes. It's just like a car endoscope being driven. It's called the power spiral enteroscope. Next slide, please. And of course, my colleague, Dr. Mohan, again, is one of the experts in the world. Technique where we can plicate endoscopically the GE junction to decrease the reflex. Next slide, please. So we now have this large series randomized control trial. My colleague, animal lab, where, next slide please, where a large number of gastroenterologists are being trained, all these new techniques, endoscopic suturing, the Gerdex procedures, all this require rapid evolution. People should get used to this. Next slide please. We also have what is so-called checklist, and every patient coming to endoscopy has undergo a checklist. Next slide please. They have a checklist nurse for every large endoscopic procedure where most of the patients are now on say clopidogrel or aspirins or antithrombotic agents. So all of this has to be checked before endoscopy is done. Next slide, please. And finally, it's very important to be, endoscopy has become such an invasive procedure that it's important to be friends with a surgeon. I started this journey in endoscopy along with Dr. G.V. Rao about 35 years back. We continue to be, except that our hairstyles have changed, we continue to be friends working in the same plane. And unless we have this type of support, a comprehensive support, endoscopy cannot be done safely. Next slide, please. And this just finally to show you, this is Peter Cotton, who was actually, last month I was in Orlando, we were doing a case together. He was assisting me in doing ERCP. Peter Cotton is known as the father of ERCP. And after we finished the procedure, he put this up in his Twitter, that he was, and to me, of course, this means a lot, because Peter Cotton, as I said, was the father of GI endoscopy. And I think in India, I'm proud to say that endoscopy, Satish would agree with me, that as a specialty has developed a large extent. And throughout the world, we are recognized as somebody who's good, at least in this subspecialty. Next slide, please. And finally, I'd like to end by saying that most of what I've shown you is not what I do, but what our team does. It's actually the team that's very important. And most of the developments, the publications that come from hospitals is because of this great team that is here. Dr. P.N. Rao is here, the great team that works together. And they do all the work and I take the credit. Thank you very much for your attention.
Thank you very much, Dr. Reddy. Please give him. Please be seated. Sessions. And then I have seen them as a senior, I have seen them growing, both the GV and then Dr. D. Gastroenterology is not liked by many of the people, who are happy with the endoscopies, and he has taken to the excellent heights, as he already said, he is a world authority in the motility disorders of the intestines, right from the esophagus to anus. Please go ahead.
The theme for the overall conference is not just talk about various areas, endocrinology, gastroenterology, cardiology, but really try and bring you up to date with what is the newest and what is the latest. And I think really Nagi did a truly phenomenal job, and so did the other speakers, whether it's talking obesity and the medicine or diabetes, talking about precision medicine. So we really are talking about tomorrow's medicine, not just what we do today, but really where we go tomorrow. I think that has been the theme, and it all reflects a little bit of what my dad used to practice. He always practiced current and what's coming in, and he was driving and pushing a lot of his postgraduates to do the same thing. This is the wrong talk. Can we go to my next? You had the right order numbers. No. This is later on. No. Disorders are really caused by dysfunction of nerve, gut, and muscle. And that is what I'm going to talk in the next 15 to 20 minutes. And we'll talk about how this has evolved and talk about new understandings, both from a mechanistic perspective and about the various diagnostic, and also it has now entered the therapeutic arena and where we are going with this. Now here is a list of some very common disorders. Nagi talked about achalasia. People present with inability to swallow food. Suddenly, over a few weeks to few months, start losing weight. Or patients will present with chest pain, like I'm sure Srinath and Dr. Dasagara will talk. Or we talked about dyspepsia, indigestion, irritable bowel syndrome. Everybody thinks they have IBS. Then chronic constipation. Who has not suffered with constipation? All of us have constipation. Stool leakage, gas and bloating, gastroparesis, reflux disease, and so on. These are all common gastroenterological disorders, but that I'd like to take you to in my talk, which is to talk about how the gut continuously interacts with the brain and how the brain continuously interacts with the gut. And so now we're calling this DGBI, which stands for Disorders of Gut-Brain Interaction, because we believe that a lot of the pain, discomfort, nausea, and sometimes even constipation and so on is because there is a dysfunction or a disconnect between how the gut, I'm sure Dr. Dasagara will be talking about that. But gut is a kind of a chaotic pacemaker. This was first described by Cahal in 1896. He was an Austrian Vienna anatomist. But we now have advanced more from this pacemaker concept into what we call as a SIP syncytium, which is really a complex between three areas, between the interstitial cells of Cahal, between the what is called as smooth muscle cells and the P. So this was a traditional tool And this is the kind of graphical response. So here, each sequence of wave propagation is where a patient has swallowed. 1, 2, 3. But we don't fully understand all the dynamics of what's happening, and there are lots of areas we lose contact. So that they became much more sensitive. Their pain became more stronger, their discomfort became more stronger when we did the balloon distension after adenosine, telling us that maybe there is some dysregulation of adenosine as a cause of chest pain. So then the next step is maybe if you can block adenosine production in the chest wall, and that may help to relieve chest pain. We don't have any good adenosine receptor blockers, so we used an old drug, theophylline, which we all know is a good anti-asthma drug. We gave this acutely to patients with chest pain. We gave it placebo or theophylline. And what happened in the second graph you can see there is after theophylline, there was a dramatic increase in the thresholds at which they were experiencing pain. So they were experiencing pain at a much lower volume of balloon distension, but after theophylline, completely normal levels of experiencing pain. So that gave us a mechanistic understanding of how pain is happening and whether we can therapeutically modulate or change this pain behavior. So that is the main conclusions here. We're still looking for a very ideal adenosine receptor antagonist. Hopefully, we will find one in the near future. Let's look at another area. Now moving on from the esophagus to the stomach. Gastroparesis is a huge problem. We've already heard a little bit about it in the diabetic world. And these are our current treatment options. We try and look at diet. We look at medical management. We have a few drugs. We have dopamine agents that help to stimulate the stomach. If people have nausea, we give them an anti-nausea drug. And sometimes we also give them what we call as serotonin neuromodulators, which helps to alter the gut-brain interactions. And then, if we move on, we started giving Botox because we thought there was some spasm, and that was the same concept that led to G-Poem, which G.V. Rao and I think Nagi just mentioned. And in some people who are throwing up so much and they can't feed, we actually put a tube called PEG and venting. And lastly, we started pacing the stomach called gastric electrical stimulation. So these are our current treatment options. Some of them are more invasive, some of them are less invasive. But even with all of this, the G-Poem is what I think, Nagi already explained everything. Less than 50% of patients we are able to treat with gastroparesis. So clearly we got to do more. And the important thing to recognize, why are patients having these symptoms? Nausea, vomiting, pain, and discomfort, and why is food stagnating? Because it is an underlying neuroenteric problem in the gut. So if it's a neuroenteric problem in the gut, the way we should be dealing with this is through neuromodulation of the gut. Now, this is a brand new approach. How can we change the nerve and muscle function of the gut without harming the gut? So that is the concept behind neuromodulation. Here is the first experiment that we've conducted in our lab in the last 18 months or so. The paper was just accepted last week, and it's going to get published in the next month. So what we did was we identified the spinal nerve roots T8 to T11, and then we apply magnetic energy, and I'll talk about this again in another area, on the back. This is all non-invasive. Patient comes like an outpatient procedure. Here you can see a subject lying down, and we apply this magnetic energy repetitively on each side, and then they get up after half an hour, 45 minutes, and go home. And with this, we were able to show in this very early pilot study significant improvement in gastroparesis cardinal symptom index score, which is a holistic score that measures all the symptoms of nausea, vomiting, satiety, etc. So this was really very encouraging. We're just about to start a randomized control study actually this month, as a matter of fact. Let's move on to another exciting area, which is small bowel. Dysbiosis means bacteria in the wrong place, bacteria overproduced, certain kinds of good bacteria not there, higher amounts of bad bacteria sitting in the gut in the wrong place. All of them causes a lot of problems: pain, bloating, gas, etc. This is given the umbrella term of dysbiosis. So in the last 15 years, we found out that patients who normally this stomach is sterile because of acid. Small bowel is also sterile because acid is bathing the small bowel continuously. Bacteria are only present in the colon. But inadvertently, if we have bacteria in the small bowel, then you get small intestinal dysbiosis or small intestinal bacterial overgrowth. So when you have this, you can diagnose with a breath test, or you can put an endoscope, and you can see we have a little catheter, and we suck juice from the small bowel, and we can culture this, and we can identify. Now we have a new system called SCBDS, or a Smart Capsule Bacterial Detection System. This is a unique capsule which, after you swallow, it recognizes when it's in the small bowel. A small window comes out, and then a little wick comes out of the window, bathes in the small bowel for about 15 to 20 minutes, and then the window closes. This little capsule is a microbiology lab by itself. It automatically analyzes the juice and then gives a report on your smartphone. What is the bacteria? What is the bacterial count? How much of it is aerobic? How much of it is anaerobic? How cool is that technology? So we did the first studies in this, and we did it actually a comparative study against the standard microbiological technique, and we found there was very good correlation between the assay and the total bacterial count, and we're waiting for more actual clinical studies with this. This takes me to a very interesting case. This lady came to see me almost 8 years or 9 years ago. 1 year history of progressively worsening bloating and severe distension. Immediately after she eats, her belly will bloat up. She felt very fatigued, and one of the most unusual complaints was brain fog. I never heard of brain fog. Routinely in gastroenterology, we are not neurologists, so we don't deal. But she said it was brain fog, and she was actually referred not by herself, not by her GP, not by gastroenterologists. She had already seen 5 gastroenterologists in Atlanta area, but actually by her boss. She was a high-ranking bank executive, but because of this brain foggy state, she was signed off some high-value checks without vetting her clients. Her CEO, instead of firing her, actually took pity on her, researched, and said, maybe there's this guy, Dr. Rao, you should go and see him. That's how she landed up in my clinic. So her only other thing was she had some diabetes, hypertension. She was taking a recurrent course of probiotics. She was on PPI, statins, and insulin. I'm going to show you a self-recorded video of this patient. This was done in 2013, This is not a doctored video, but she just eats food and see what happens to her belly. This is within 30 seconds. Let's see whether this video actually works. The video on Jay. So her belly is fairly flat, and you can see within a matter of 30 seconds, it is blowing up right in front of you, and it's unbelievable. I mean, this is not a doctored video. She becomes pregnant in less than 30 seconds, and she's like 9 months pregnant. And just to be sure that this is not something she's brought this video to me, and this was so dramatic, I really couldn't believe it, and she gave it to me so that I can actually use this for teaching purposes. And this literally changed my approach to these patients. Just look at her belly, what has happened to her in such a short time. So this then led to a real work about why are these patients developing brain fog so they have developed a new metabolic condition. So we measured urine lactate after giving her a glucose meal, and the lactic acid went up, and her hydrogen levels also went up. We then went on. Now we're just going to publish this paper with 105 patients. What we've seen is everybody's using probiotics almost uncontrolled manner. If you take probiotics, if the probiotics get to your colon, it's good. But if it stops halfway, spills all the probiotics will colonize your small bowel, and that is what is happening. When probiotics colonize small bowel, they ferment food and produce D-lactic acid. And then when we treat them with antibiotics, it leads to reduction of D-lactatemia and also improvement in their brain fogginess. So you're predisposed, you eat a carbohydrate meal, you become brain foggy, and then you become bloated. And this is a cycle. So we've actually shown that this can be improved. The last part I want to talk about is innovations in colonic and rectal disorders. And generally, we rely on history as a very good tool to tell us what's happening. Here we compared history with a prospective bowel diary, and we showed that history was very poor. Concordance was only 25 to 12% for any symptom, such as number of bowel movements or stool consistency. Sometimes they overestimated, sometimes they underestimated. So we can do better by actually prospectively collecting this information through digital diaries. There's constipation diary, FI diary, gas and bloating diary. There's also My GI Health app, and all of these are very important tools. You have a patient module where patients can look at these nice cartoons and record, and then investigators who are interested in studies, there's an investigator module that can also be used to improve this. We then just want to finish up by talking about the lady with severe rectal hyposensitivity. We now have a new tool called TAMS, where we apply a magnetic coil on the back, and then we study nerve conduction. And here you can see this lady, young lady who fell off in a diving accident, severe neuropathy following the accident, and this TAMS test can be extremely useful. And the TAMS test then led to a new treatment called translumbosacral neuromodulation therapy. We applied this treatment for fecal incontinence, where again we applied the magnetic coil at 4 different levels, and we did this in our first clinical trial. The first time in the world this kind of a technology is being applied to humans in a non-invasive way, and we showed that we were able to improve stool leakage dramatically. At a 1 hertz frequency, 91% of our patients had 50% or more reduction of FI episodes. At 5 and 15 hertz, less so. So this kind of technology is now coming in, and it can be applied to a number of GI enteric neuropathies. Finally, a new device we treat with drugs, as Nagi was saying. But now we have a pill that after you swallow, this will gently vibrate inside the body. And we've shown in this first clinical trial, just got FDA approved about 3 weeks ago, where in this randomized controlled trial, we showed there was significant improvement in number of complete spontaneous bowel movements, both 1 increase and 2 increase over everything. So lastly, talking about biofeedback therapy, a patient with severe constipation. Traditionally, we used office-based biofeedback therapy, but in this study, we showed office is as good as home-based biofeedback therapy. Traditionally, the office biofeedback therapy, you place a probe, and then they look at this monitor and the waveform and have to try and understand the waveform. We're going to change this with this new wireless, real-time, realistic Bluetooth interactive system where they can see anatomy, see a stool coming down, and we're going to work against resistance, or they can actually understand and connect with their own body, rather than look at waveforms, which is easy for scientists, but not very good for clinicians. So, my family is here. I'd like to, they send their regards, and I'd like to thank them for giving me the opportunity to all of this. And to conclude, neurogastrointestinal GI motility has come of age. It's a major, major subspecialty. There are significant new advances in diagnostic modalities that reveal pathophysiology, provide accurate diagnosis, as well as improve apps, PROs. We are talking about the SCBDS capsule, the smart pill capsule, neuromodulation therapies, which are all very non-invasive therapies, and hopefully newer methods of biofeedback, with which I'm sure we can really help many of our patients. Thank you for your attention. The way in which we'll be able to practice this in future.
Thank you.
Thank you very much.
Apps, if you can send some list, I can try to use them in my patients also. Thank you.
Okay, thank you. I'll be closing the session for you to take back and think about 2 things. One is a magnitude.
Welcome Dr. Shantaram sir to present his topics.
Good morning everyone, and it's an honor for me to be associated with this function. I think Dr. Satish and Srirang, they have included me in this. I'm so happy because this is addressing after 60 years of my entry into medical college. I think in 1960 I became a medical student. And of course my colleague Dr. Dayasagar also must be 1 or 2 years contemporary to me only. During this 60 years, my own personal experiences could be of value to Satish, who is son of my teacher. Is till death in the life of a doctor, associated with sublime relationship between teacher and student. And finally, it is the students who inspire the teachers. Today, all my students, even the chairman is my student, members of the audience are my student, Satish is my student, I think Rakesh is my student. Most of these people are all, Dr. Singh is also my student. Therefore, the students inspire the teachers, and teachers are always proud of their students. But one point I want to tell, because Dr. Dayasagar is MRCP, FRCP, and DM cardiology, and is the father of intervention cardiology in our state. And I have become his own student in one way, though I was his colleague. Similarly, Satish reached the zenith of his career by doing all that is not done in Hyderabad. Nageshwar Reddy was suddenly dwarfed by the fact that this is not possible in India. So he rose to a zenith of his career in doing something unfathomable to be proud of as Osmania and as our student also. But one thing, Robert Hutchison in 120 years back, I think you MRCPs and FRCPs should be very clearly remembering him. And we know Hutchinson under clinical methods. He said, from inability to let alone, from too much of zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, cleverness before common sense, and from treating patients as cases, making the cure of the disease more grievous than endurance of the same, good Lord, deliver us. Thank you very much.
From 1959 to 1964, Osmania Medical College. He was looked upon as a role model, both for his discipline, strength of knowledge, and placing the profession at a much higher pedestal than many of his colleagues. He never allowed any of the politicians to come anywhere near, and for that he paid the price too during his tenure as a professor of medicine in Osmania. I don't want to go into the details. But my association and my appreciation grew much more when I was invited to come to the Durgabai Deshmukh Hospital, of which he was the chairperson during those days, and he invited me to come and establish the cardiovascular wing. And he had a vision, and he pursued it, and he turned a nursing home, Durgabai Nursing Home, to a Durgabai Deshmukh Hospital and Research Center. He turned it from a nursing home to an academic institute where the postgraduate training for gynecology, medicine, and cardiology. Believe me that the first private center at that point of time to be recognized as a center of excellence for training to be given to prospective cardiology specialists. So that was his focus. Unfortunately, after he left, the center lost focus, and probably, I don't want to say anything more on that. Be that as it may, I thank the organizers of this meet for inviting me to share some of the advances in cardiology which have some relevance as on today. Now, what is academic medicine now is quite a lot of people come in and say, sir, I want to have academic teaching and all the academic advances in these things. And for me, academics is translating the state-of-art knowledge to the patient care. So that is academic medicine, and that's what we try to do it. And since the growth of knowledge is very, very high and very, very fast, it is difficult for any single individual to read all the literature and then distill it out and then apply it for patient care. So the simpler thing may be to read the guidelines given by professional organizations. Like for cardiology, it is Cardiovascular Society of India and Indian College of Cardiology. And for international lines, American College of Cardiology, European Society of Cardiology. They formulate the guidelines based on analysis of various studies published all over the world. So my talk will be, since the advances have been far too many, I thought I will just discuss some of the things like changes in the concepts, in the understanding of the disease, changes in the investigations and diagnosis, and finally some advances in therapy. You may be wondering why there is a change in the concepts. When we were students, that the definition of normal blood pressure was different, and the definition of normal blood pressure today in 2022 is the normal blood pressure is 120 by 80 millimeters of mercury. And we are telling anything more than 140 by 90 is stage 1. And what we were calling as pre-hypertension about 5 years back, we are labeling it again as stage 1 hypertension. Anything more than that is stage 2 hypertension. So the concept of a normal blood pressure and the concept of a hypertension has changed over the years. And as I said, anything more than 140 by 90 demands a treatment, be that a non-pharmacological or pharmacological treatment. Not only that the definition has changed, even how to measure the blood pressure, where to measure the blood pressure, and who should measure the blood pressure has changed. For example, should we measure the blood pressure only in the clinic and then label the patient as hypertension? Or should we measure outside the clinic as well, just to label the patient as hypertension? It is important to remember that a diagnosis of hypertension based exclusively on the physician readings is no longer acceptable to label it as hypertension. You should not only measure the blood pressure in your office, but you should also have data on out-of-office blood pressure measurements. What do we mean by out-of-office blood pressure measurement? Is measurement done in the usual environment, be it in the working place or be it in the home place. So blood pressure measurement in the clinic should be combined with the blood pressure measured out of office. And for that we have two options. One is continuous ambulatory blood pressure measurement, which unfortunately is very expensive for most of us. And probably the simpler method is to measure the blood pressure at the home by the patients and the family members, and thus label it as hypertension. So it is important that usually what we used to measure was the blood pressure in our clinics and then say more than 140 probably should be labeled as hypertension. It's no longer accepted now. Same thing applies for measurement of jugular venous pressure. We used to believe that you should measure the blood pressure, the venous pressure in the internal jugular vein or the external jugular vein and relate it to the manubrium sterni. But then the studies have shown that there is that the relationship of manubrium sterni to the midpoint of right atrium is not constant as it is supposed to be. And now the current standard says that you measure the venous pressure in the sitting posture of the patient, and then if you find a venous pulsations above the level of the clavicle in the internal jugular vein, then only it is venous pressure is elevated. Otherwise, venous pressure is normal. So we have got only one condition, that is whether venous pressure is elevated or normal, because there is a very poor correlation between the evaluation of venous pressure at the bedside with the catheter measured venous pressure. So elevated or not elevated or normal are the two different terms. Most of the advances in cardiology started with the advances in the cardiac imaging. In 1970s, we never had echocardiography. You'll be surprised to know that Hyderabad did not have any echocardiography of any type till it was 1978 to 80. We never had an exposure to it. And the only institution which had some semblance of a echocardiography or ultrasonography for cardiac use, surprisingly, was in the Institute of Genetics, and where we had to take the patients to do an M-mode echocardiograph after the local scientists completed their work. And I used to carry the patients from Nilafar Hospital. At that time, I was the cardiologist there, along with the mothers, and then wait till 2 o'clock and then start doing mode echocardiography. But now, today, you cannot practice cardiology without echocardiography. Not only there is echocardiography, now further on, we have moved on to computerized tomographic radiology, MRI, cardiac MRI, PET imaging, and perfusion imaging, so on and so forth. I'll give you some of the examples of what we are doing it. Now, 2D echocardiography Doppler is very, very useful. It not only defines the anatomy, which we never had an access to the anatomy before the advent of echocardiography. We can see how many chambers are there. We can see the normal sizes and of the atria and the ventricles, atrioventricular walls, and semilunar walls. So we had a definite anatomy, so we could localize the pathology. Suppose you find a murmur and the anatomical abnormality is in the semilunar wall, we know it is an aortic stenosis. Same way, you have a mitral regurgitation and then you found that there is a mitral wall prolapse. So you not only know the anatomy but also the etiology and the pathology. I think it is very important because now echo Doppler gives you not only the anatomical abnormalities, but also the functional abnormalities, so you can evaluate the hemodynamics, whether the blood is moving in the right direction or in the opposite direction, how much blood is moving, at what velocity it is moving. So it is very, very important that people, even general physicians, should be aware of the importance of getting an echocardiography. They may not be able to do it, but they should be able to interpret the data. So see the anatomy, see the hemodynamics. It is very useful because it is a non-invasive, it is less expensive, and it can be repeated so that you can follow up the patient. Patient with a mild aortic stenosis, what is happening after 5 years when he comes? Has it progressed or has it remained at the same level? So knowing the echo Doppler, or at least interpretation of the echo Doppler, becomes very important in the evaluation and therapy of cardiovascular disorders. So much so now it has become the gold standard for evaluating the valvular heart diseases. It is not the cardiac catheterization now, but it's the echo Doppler that really is the standard for evaluation of the severity of the valvular heart diseases. Now, just to emphasize here the role of echocardiography in the diagnosis, is a case scenario, a 50-year-old male. First episode, he had transient hemiplegia, and all the entire neurological evaluation was totally normal. So the patient was referred to us to see whether any possible cardioembolic stroke. And then what we found was, but more relevant and more useful for these patients of biomarkers is usage of troponins and troponin elevation in a patient with suspected chest pain or coming into the emergency room. Troponins have really helped in diagnosis. This is an acronym called chest pain for heart. You just use the word heart, H standing for history, E standing for electrocardiogram, A standing for age, and R standing for risk factors, and T for troponins. So this is an algorithm, diagnostic algorithm, wherein if your symptoms are atypical, ECG is borderline, but the troponins are elevated, you treat them as acute MI until proved otherwise. If the first value of troponin is normal, you please repeat the second value after 2 hours, and the second value is also normal. Probably the patient does not have an acute coronary syndrome, but you don't have to admit the patient, ask them to come and attend the cardiology outpatient for further evaluations. Heart failure has become a common disorder, and it's the end result of many pathological cardiovascular disorders. Treatment of heart failure has moved on from the good old days of digoxin and diuretics to very many drugs. That the discovery of the SGLT2 inhibitors as a good drugs for heart failure has come more by accident than by design. It was in 2008, Stephen Nissen, a cardiologist from Cleveland Clinic, has produced a paper saying that those people who are using rosiglitazone had a higher cardiac event rates. That paper had a very stormy outcomes in the sense that it raised a lot of eyebrows, a lot of criticisms about the way it was interpreted, but that led the FDA to impose that all further anti-diabetic drugs should have a cardiovascular outcomes as one of the outcome measures. And that started the saga of evaluating the cardiovascular disorders, and then started with the SGLT2 inhibitors. So SGLT2 inhibitors were tested for anti-diabetic efficacy, and suddenly they found they were doing less decrease in blood sugar, but more importantly, they were decreasing hospitalization for heart failure, recurrent hospitalization. That's how SGLT2 inhibitors came into existence as a form of definitive therapy in the management of heart failure. The conventional treatment now in 80s and 90s has been that you have the usage of SGLT2 inhibitors, but even the sequence of administration of these 4 pillars have been changed. The conventional thing was we were going on adding sequentially, start off with one drug and then keep adding the drug. So much so that we used to take at least 3 to 4 months for the 4 pillars to be in the acceptable range. Now the current thinking is all the 4 drugs in a very short period of time. So one line is 4 drugs in 4 weeks should be the drugs. So you use 4 drugs in 4 weeks and then up-titrate them subsequently. So the concept has changed that from a sequential administration of these anti-failure drugs to a simultaneous administration of all the 4 drugs is the rule now. So what do they achieve, the SGLT2 inhibitors? Most importantly, they are preventing the readmission for heart failure. To a lesser extent, they are also decreasing the cardiovascular death. And to some more smaller extent, even reduction of the vascular events. But be that as it may, the most expensive part of therapy of heart failure is the recurrent hospitalization for fluid overload. And that is effectively prevented by the administration of SGLT2 inhibitors. So the drug therapy has moved on from decongestion to diuretics to the 4 pillars of treatment. Now, one of the common problems now with increasing aging population is the frequent occurrence of atrial fibrillation. Difficult to recognize at the bedside, but if you feel the pulse for any length of time, about a minute or 2, you will suddenly find that the pulse is irregular. All these patients should have at least 1 electrocardiogram. But first thing is, you need to feel the pulse. You need to measure the blood pressure. And then you will find out that the pulse is irregular. So the treatment of atrial fibrillation is not as straightforward as many people thought it would be. So classically we say the commonest cause of atrial fibrillation in India at one time was only rheumatic valvular heart disease. But with the increasing population, we are finding it that atrial fibrillation is due to what we call non-rheumatic. And so that's the reason why we say now you classify atrial fibrillation into 2 categories, valvular atrial fibrillation and non-valvular atrial fibrillation. And then there are some criteria. We had only one set of anticoagulants for this treatment of these patients.
Sir, please.
But then,
time.
Sure. I'll be finishing in 1 minute. So the novel oral anticoagulants have come into existence, and they are basically dabigatran, rivaroxaban, and apixaban. But I think you need to remember that before you use these novel oral anticoagulants, kindly remember the ABC. A standing for age, B standing for body weight, and C for serum creatinine. All the novel oral anticoagulants are metabolized by the kidney. So basically, if there's a kidney function is effective orifice area is as good as the surgically implanted wall. And there are some data to show that catheter-based aortic wall replacement is less prone to degeneration as compared to surgically implanted biological walls. So now there is a move that catheter-based aortic wall replacement should be done even in the younger patients, because as things stand today, it is only meant for those people where the surgical risk is very high and where the patient's age is more than 75 years of old. In conclusion, there have been some changes in the concepts in the measurement of various parameters at the bedside, like blood pressure and venous pressure. There have been some changes in the endpoints of the effectiveness of the drug therapy, like reaching the target blood pressure now for all conditions is you should reach the blood pressure to 130/80 preferably, or even less than that if the patient can tolerate it. Newer methods of investigations have come in, newer drugs have come in, newer modalities of wall replacement has come in. But everything comes with a price, and the success depends basically on selection of the patients in a given individual clinical situation. Thank you, ladies and gentlemen, for your attention.
Request Dr. Sanjeevi sir to please. Thank you.
Trying to prepare this. Sheila will vouch for it. But I think what I would like to do over the next about 12, 13 minutes is perhaps share with many of you some things that we bring from a family side, as well as some things that many of you may not remember, have forgotten. And it took me, along with all the research that I do, a lot of research to try and get this talk together. So I will share with you Dr. SRO's childhood and schooling, a little bit about his family, his medical career, which most of you are familiar with, some of his achievements and contributions, and importantly, some unique this particular generation began. This is my grandfather, Mr. Janakiram Naidu, and my grandmother, Mrs. Janakamma. They are Dr. SRO's parents, part in Secunderabad. But these grandparents of ours really were legendary in a sense that they created a whole generation of physicians. Of course, my father is the famous one, but there have been a whole lot. And in fact, it was so interesting that Amlesh, who is here, my brother, he's actually put our entire seventh one, and regrettably, I was unable to find a picture of that. But right at the top corner is Dr. Narayan Rao, who is my eldest uncle. He was a physician in the central government services, worked in Delhi, Andaman, and several other places. Right next to him in order is Mr. Vittal Rao. He was an agricultural scientist. He did his master's in Cornell University, and then came back and joined Ambarpet, which was the maize center at that time. Eventually, he retired as the registrar for Andhra Pradesh Agriculture University, a highly distinguished and accomplished person. Then the third person whose picture we are missing is Mr. Venkat Rao. He, what I understand, was a winner of the Indian National Badminton Championship. He represented the state, the Nizam state at that time, for national competitions, and then unfortunately he succumbed at a very early age of 19 or 20 to some obscure illness. Fourth is, of course, my dad. We'll talk about him during the rest of my presentation. The fifth one in this order is by far the most colorful, most energetic, and most flamboyant character in the entire Sanku family, was Mr. Devendra Rao. At a very young age of 30, he became the Assistant Commissioner of Police in Hyderabad. And he had a little topsy-turvy career, partly because of his personality, I bet, but he was the most colorful uncle that I can ever remember. Then next to him is Mrs. Vimala Bai, their only sister, and some of my cousins are here, Vimala Bai's children. And she was a wonderful lady and favorite of my grandmother. And the youngest is Rajender. You can see with his smile, my children would call him Laughing Tata because he always smiled. He said, hello, ha, 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 ha. So, he had that great enterprising thing. But that's Rajender. He was also a scientist in the regional research labs and a PRO there. So that was the family he was born. They were all very hardworking, very humble beginnings. They were very in the lower middle class. My dad went to school in Mehboob College. This is some of the pictures of Mehboob College. And for those of you who are not familiar with some great alumni of Mehboob College, there's Sham Benegal, there is Muhammad Azharuddin, the captain of Indian cricket team, Admiral Ramdas, M.L. Jaisimha, another cricketer, and Mohan Khanda, and so on. So some interesting research. After completing his undergraduate, his schooling, he received the Sturge Scholarship, a unique scholarship, one scholarship they would give a year for pursuing his undergraduate studies at the Nizam College. He graduated with a BA and stood first in mathematics, which was his primary interest. But somehow he was persuaded to go to medicine, largely by my eldest uncle, I think. He wanted to actually pursue engineering. He went to Stanley Medical College in Chennai, and then he received a gold medal distinction. And you can read quite a bit of the biography. And by the way, I'd encourage all of you to please read the commemorative booklet that we have put together, which has nice biographies of all the speakers and their achievements, but also all the past awardees of this oration that we are here to celebrate today, and also some biography of the family. He graduated from Stanley Medical College in 1946, and then he received the Nizam's, his High Excellency Nizam Scholarship for pursuing postgraduate studies in MRCP. He took a ship that took him like 3 months from Mumbai or so to go to London. And then he graduated with a MRCP in his very first attempt. He obtained his membership. And then in 1972, he received the fellowship of the Royal College. Of course, you can see the difference in the Royal College buildings between 1951, when he went to school, and 1972, which is the new modern building that was completed in the late 60s. Then he came back to Hyderabad. In 1954, he was married to my mother, Mrs. Jagat Kumari. This is the house my mother came from, an old British home called Stone House. It has all stone facade in the front and everywhere in Egmore. That's her brother and his family in that picture there. After marriage, they moved into this home, and he settled, and he lived in this home till his last breath. In fact, he passed away in his own bedroom on his own bed. But many of you remember him, visiting him, and he had his clinic, a lot of his patients. And I'm sure Srinath will remember this very well, because it was in the same lane. The very first home was where Srinath grew up, and then 5 homes down the street is where this home was, in the same street, number 9. This is a family picture. In 1964, there's me and there's my dad and mom. Me is the oldest, then my sister Sangamitra, and then Amlesh, and Sunil is the little baby there, probably 1 year old. A picture in 1974, all of us. And this was my dad's 25th wedding anniversary with a little bit more extended family. You can see some of my uncles, my cousins, and the eldest uncle, and so on. They're all here. My mom right in front of that candle. I'm having a problem with the slide changer. I think the battery is dead. Next slide. Next slide, please. Slide, please. After retirement, as Dr. Dasagar Rao has nicely put, he was invited by, in fact, Durgabai Deshmukh to this Andhra Mahila Sabha hospital to chair it, and he was served as its chairman for about 8 years. And here he opened the subspecialty clinics, first mobile IC unit, first open heart surgery unit, first PCTN surgery in South India, and also he facilitated development of research center and inaugurated GI endoscopy unit. So this nursing home became a major academic-focused institution, and so on because of this. His passion was really teaching postgraduate students, and here are a number of them. Some of you may recognize. Next slide, please. And this is the top picture is actually my own batch. I'm somewhere in that crowd, but most of you may recognize that auditorium in front of which we all stood and took year after year after year pictures. This was when he was principal of Osmania Medical College. In the bottom left, there's a picture. He was very fond of taking his students and postgraduates for picnics and get together at least once a year. And that was a picnic that we had the privilege. I and Amlesh are the two young kids in the front that we went to Nagarjuna Sagar. There's an older picture of him with other professors on the other side. I didn't know which year it was. Next slide, please. He had many honors and awards. This was one picture that we all were very proud of. There's Dr. B.K. Nayak on the left. I don't know if Uday Nayak is here, but there's with Babu Rajendra Prasad, our president, who fell sick. Babu Rajendra Prasad used to actually like to come to Hyderabad and spend his winter months, summer months here. And then he fell sick, and both my dad and Dr. B.K. Nayak took care of him. There are two important honors in his career. One is for being an eminent medical teacher, the Dr. B.C. Roy Award, and also he was very proud of this award, the Amrut Modi Research Award, for his work on fluorosis. I want to spend a little bit time, and then there are several distinguished honors and medals. This fluorosis was an unusual epidemic that suddenly happened in the early 60s in Andhra Pradesh. Very deformed, of these skeletal muscles got deformed, the bones were deformed, the teeth were deformed, and fluorosis was rampant. So what they did under many postgraduates, this was a research and evolution for almost 8 years. They first tried to map out where these cases were happening, and they found they were mostly happening along the banks of the river Krishna. Then they said, why is this happening? Was because of Nagarjuna Sagar Dam. Because of the dam, the Krishna River water already has a slightly higher fluoride content. But once you build the dam, then the water table level across all of these areas, in all the wells, the fluoride concentration went up 10 to 100-fold. And when the farmers and kids were drinking this fluoride water, they really developed this fluorosis. And this is one of the old research work that he did. But then they also went on, not only they identified the cause, but they tried to treat this with an asbestos waste, which was the serpentine. And this was it was a kind of a dechelating agent which removed and extracted the fluoride out of the body. So some very exciting work. He had a very small group of friends. Mr. Gopal Rao was the chief engineer of Nagarjuna Sagar project. Quite an irony. He did research because of the dam, and Gopal Rao actually built the dam, who was his neighbor and a very close friend. Justice Obul Reddy was a very close friend, and then some of his physician friends, Dr. B.K. Nayak, Dr. Shantinaran Mathur, Dr. G.P. Ramaya was a very, very close friend, and his children are my close friends, and interestingly, yesterday was Dr. G.P. Ramaya's oration. What a great coincidence that both of their friends are having this. And of course, Dr. Ramesh Pai. My dad was also a great admirer of Indian culture, art, tradition, religion. This is a picture of my sister who passed away 2 years ago. She was a very gifted, talented artist and Bharatanatyam dancer. At the age of 9, he celebrated her Arangetram at Ravindra Bharati. This was a picture taken with Justice Jagan Mohan Reddy, who was the chief minister, who was the Justice of the High Court and then became Supreme Court Justice. He was a very religious and a pious man, celebrated many festivals, very fond of astrology, and of course, the Ramalayam temple, he donated a Krishna Murti and so on at the temple, and so on. So there were some unique attributes. Some of you may remember, in fact, I was recalling with some of the people. One was his ability to do ambidextrously. I've only seen him once from a distance. I just entered clinical medicine when he retired. And interestingly, I was trying to figure out, we would play cricket with us, at home, and he would bowl left-handed and bat right-handed. Then I found out that Zahir Khan, one of the he also was the same. bowl left-handed and bat right-handed. I don't have a picture of my dad doing it, so this was the best I could do. His pastime was really listening to radio and later on to television, but he would have a cup of tea and really listen to the 9 o'clock news very, very devotedly. If he ever had a free minute, his favorite pastime was reading the British Medical Journal and the newspaper over his breakfast. That is how he would spend his time. So, ladies and gentlemen, I wanted to end with a famous quote that he would say. This was from Longfellow. Lives of great men all remind us that we must make our life sublime, and departing, leave behind us footprints on the sands of time. Footprints that perhaps another, sailing over life's solemn main, a forlorn and shipwrecked brother, seeing, shall take heart again. Let us then be up and doing, with a heart for any fate, still achieving, still pursuing, learn to labor and to wait. I present to you the Doyen of Hyderabad Medicine, my beloved father, a beloved professor, inspirational teacher, astute physician, a brilliant administrator, and most important, a humble and compassionate person. Thank you very much.
He is going to speak on responding to India's health challenges. Dr. Srinath Reddy.
Before we begin the talk, request our orator today, Dr. Srinath Reddy, all the chairpersons and family of Dr. S.R. Rao to please garland the portrait of Dr. S.R. Rao, sir, and pay our respects. Would request all the family members of S.R. Rao, sir, to please join us for the photograph with him.
It is indeed the honor of a lifetime to have been asked to deliver this oration celebrating the life and contributions of Professor S.R. Rao. The achievements have already been detailed, but as a student, it is still a matter of pride to recall under whom I studied. An extraordinary clinician whose diagnostic acumen was amazingly accurate without technical aids. A brilliant teacher who mentored, motivated, and molded his students. An assiduous researcher who explored the causes and cures of fluorosis. An able and unbiased administrator who set standards of governance. A role model to all his students and other colleagues for his unwavering commitment to principles and ethics, and as has been noted, an aficionado of fine arts, truly a Renaissance man. To quote Shakespeare, the elements so mixed in him that nature might stand up and say to all the world, this was a man. It is a matter of pride to speak today while commemorating his contributions. Let me first offer not an apology, but a plea for an anticipatory bail. After all, outstanding clinicians have spoken so eloquently. The under 5 mortality, which is now even better than that, it's about 32 at the moment. The infant mortality rate, as by statistics revealed only 2 days ago from the latest survey, is now about 28. And the maternal mortality ratio is also fairly low. And these are near the average income level globally. Yet, India ranks 132 in the Human Development Index. A number of surgeries were delayed. Therefore, the lesson from COVID is very clear. We need an efficient, equitable, and empathetic health system functioning reliably in the steady state, even without a public health emergency, if we have to ensure a swift, strong, and sustained response to a public health emergency when it comes. And primary care is pivotal to a well-functioning health system. It's not just hospitals and ventilators. You need a very strong rural and urban primary health care system. And of course, it's not that infectious diseases and NCDs exist in 2 watertight compartments. We have seen how COVID claimed its maximum number of victims, whether in terms of severe disease or in terms of death, because of comorbidities related to non-communicable diseases. So if your health system does not detect them in the first place, does not treat them effectively, you're going to be surrendering human bodies to the virus. Health expenditure to total health expenditure, India features very poorly in comparison to many countries. Leave aside the developed countries, even in comparison to a number of developing countries. Like, for example, if you look at Thailand or Sri Lanka, their levels of government health expenditure as a proportion of total health expenditure is much higher. Even the United States of America, the poster child for privatized care, has about 48% from government expenditure. And as a result, we see very high levels of out-of-pocket expenditure. Though the recent statistics say that it's about 48%, still compare it with others, and much of the decrease from 62 to 48% has occurred because of increase in capital expenditure, buildings, rather than actual services provided. So that is a major problem again. Do we have the health workers we need? WHO says we need 44.5 per 10,000 doctors, nurses, and midwives to achieve universal health coverage and sustainable development goals. You take all the numbers, you take even dentists and Ayush, you still have 33.7. This number of beneficiaries because of equity reasons, but also because they're the vote banks. But the health professionals would like to have as many services covered as possible because they feel my patient deserves the best. Cochlear implant, cardiac transplantation, costly chemotherapy, monoclonals, whatever. The people who are holding the purse strings, the health system managers, the people in the Niti Ayogs and the planning commissions, the finance ministries, They are cost conscious, but they also want to spend the money to reduce poverty, to reduce financial hardship, without the overall budget going bust, with financial prudence. There's a dynamic tension between the three of these stakeholder groups. At each stage of universal health coverage planning, you'll have to balance that tension through what we call a standard package which is developed. But that package is, of course, based on disease burden, treatment effects, cost effectiveness, and so on. But equity matters, because at every stage you have to look at equity as an important dimension. There's a horizontal equity, which goes like this, where the package provides common services to everybody, rich or poor, doesn't matter. But there is also a vertical dimension where you are trying to provide additional services or additional resources to the most vulnerable groups who have had health inequity, to try and bridge the health inequity gaps. So that is something that has to be also looked at. So in universal health coverage, you can have the government as the purchaser, principally tax-funded, or social insurance programs, employer-provided insurance, privately purchased insurance. The provision is by a public sector, but also private sector and public-private partnerships. But even while we are dealing with a mixed health system, where the government is not the sole provider, and it need not be, it has to be the guarantor of services, of access, affordability, and quality of services. To measure the impact, whether actually universal health coverage is doing its job in terms of cost reduction, we'll have to measure out-of-pocket expenditure, catastrophic health expenditure, and healthcare-related impoverishment. Some of our currently existing insurance programs are not serving that purpose. The same proportion of people are getting impoverished because of unaffordable healthcare expenditure. But we also need to measure service coverage, to what are the services being provided and to what extent. But quality matters too. You cannot say it's only cost and access. But how do you define quality? There are all kinds of descriptions, but I simplify it for myself like this. Is it beneficial? Is it safe? Is it cost optimizing? And is it providing satisfaction to patients, families, and to the providers? The doctors, nurses, and technicians working in the hospitals also must have the satisfaction that they have the right kind of equipment, the right kind of administration, that there are no stockouts, and patients are not coming up and beating them up because of administrative failures of the government. So all these need to be really addressed at the same time. So this I've already dealt with, that we need to strengthen health system performance. We need to have primary healthcare-led universal health coverage, a multi-layered, multi-skilled health workforce, leverage technology to improve service delivery, engage all sectors, public, voluntary, private, and Ayush, for optimizing health service delivery. We pack all of this into recommendations of a committee called the High-Level Expert Group on Universal Health Coverage, which was set up by the Planning Commission. I chaired it, along with 14 other colleagues. We presented all of these as a package of recommendations to them. It took a lag time. The National Health Policy of 2017 adopted many of these, and some of these are now being rolled out as part of the national programs. And you see that also in Ayushman Bharat, where the Pradhan Mantri Jan Arogya Yojana focuses on secondary and tertiary care, but primary care, which is the broad base of a good universal health coverage system, which was previously only providing for 15% of the common health conditions. Non-communicable diseases, mental health, a lot of these conditions were not covered. Now comprehensive health coverage plans to cover them. It still is a process in motion, but at least now there is a plan to have primary, secondary, and tertiary covered, but we need better linkages between them as well. And the 15th Finance Commission and the Union budgets of 21 and 22 are focusing on strengthening health services with a greater impetus for primary care, urban health, disease surveillance, allied health work manner, tertiary care with medical colleges, hospitals, and private. But all of these need to be connected as well, connected both horizontally and vertically. Unless that happens, you will not have that seamless continuum of care. And this architecture can pave the way for an integrated healthcare system and health financing based on a single payer system and what is called a capitation mode system, in which the payment takes care of a person's illness, irrespective of whatever illnesses are, for a certain sum. And that's the kind that Kaiser Permanente system and the NHS in UK adopt, and that's the kind of system we must try and work towards. The role of the government is to strengthen public sector and contracted private sector, public financing from tax revenues, pooling from a single payer system, and strategic purchasing, so that you can actually purchase, like the Tamil Nadu Medical Systems Corporation. You actually set standards and then invite bids, cut out the middlemen, and save a lot of money, but assuring quality. And we require to strengthen our regulatory systems as well. The role of the ethical private sector would be to participate much more energetically in primary care, to participate in the Pradhan Mantri Jan Arogya Yojana in secondary and tertiary care, with some of the glitches yet to be removed. Pooled procurement. There is no reason why private sector hospitals also cannot undertake pooled procurement, negotiate for better prices, assure quality, and pass on the benefits to the patients. And of course, we need integrated networks, as I said. And when we talk about public-private partnerships, actually, I would like to redefine PPP as partnership for public purpose. So the private sector and the public sector must join hands in a meaningful manner, prioritizing public interest as topmost. So if we take 3 concentric circles for health assurance of the society, the innermost circle is health financing, tax, as well as social insurance, as well as other payments from employers, etc. But that gives entitlements, does not give delivery. For the delivery, you require the second concentric circle, in which all the elements of the health system are there: infrastructure, health workforce, drugs, equipment, and vaccines, technologies, and health information systems and governance. But even that may deliver universal health coverage, but doesn't create a healthy society. For that, you need to address the social determinants of health, like water. We just heard about Nagarjuna Sagar did to fluorosis, or any other conditions like that. Environment, and personal attributes like education, gender, all of these become very important in determining the health of a society. I'll conclude by briefly drawing attention to these elements. The Swedish Nobel laureate Gunnar Myrdal said, "Health leaps out of science and draws nourishment from the totality of society." Now, we may be talking about respiratory diseases and all the technological advances that we can actually have to deal with respiratory diseases. But we still have to recognize that air pollution is causing cardiovascular diseases, respiratory diseases, diabetes, and obesity by creating a huge amount of inflammation. And that is something that we are going to face as an increasing challenge in this country if we do not address it. Not only ambient air pollution, but also indoor air pollution. All of these we need to address if we have to reduce the disease burden in this country. Climate change is going to be the biggest challenge in terms of burdening our health systems. Apart from heat effects, which will debilitate both physically and mentally, we'll have a spate of waterborne diseases and water insecurity. We'll have vector-borne diseases, extreme weather events, exacerbated air pollution. As the carbon dioxide cloud descends, it will trap the pollutants closer to the Earth's surface. We'll have climate refugees, increased risk of chronic diseases, impact on agriculture and nutrition security. I'll conclude by drawing attention only to a couple of these. When we talk about vector-borne diseases, particularly caused by mosquitoes, as temperatures increase, as humans will lie listless and wilting in that heat, the mosquitoes will become more athletic, and they will climb to higher heights and spread farther to new areas. Malaria, dengue, chikungunya, all of these are going to become problems. They will be changing spatial patterns of disease, longer transmission window, shorter extrinsic incubation period. Our health systems will have to deal with it, even as we try and reduce global warming. Nutrition. Sub-Saharan Africa and South Asia, India included, are particularly prone to productivity losses. Already our rice and wheat are being produced at the virtual limit of temperature tolerance. For every additional 1 degree rise in temperature, we'll lose 10% of our rice and wheat crops. And not just the quantity, look at the quality. Because of water stress, heat stress, and carbon dioxide, 3 stresses, the nutrient quality of crops will decrease. Protein, iron, and zinc will decrease.
And the teachers here, Dr. Sabu, and also senior citizens, my colleague, Dr. Bhargava, we find we have not gone to America or abroad in either case out of circumstantial factors. But I think Srinath Reddy on one side, and then our young Satish Rao on the other side, have given a glimpse what an Indian can do in the medical science, social science, and both of them represents a polar type of a phenomena. One is interested in the motility of the gut and done a research and got 3R, research qualifications and complement from USA, teaching complements, and most important, the practice also. Similarly, Srinath Reddy on this side is something, a climax of a teacher's ambition being fulfilled, namely, from Olympic heights of Professor of Cardiology, All India Institute of Medical Sciences, treating Prime Minister and ordinary peasant also. Similarly, on all the state-of-art recommendation, he has become encyclopedic in understanding what India requires, what Indians require, almost reminiscent of Mahatma Gandhi coming back to the basal levels of Harijans and trying to emancipate India from the foreign rule. I think we are celebrating 75th birthday of Indian independence. In that context, I personally feel he should be labeled as a Gandhian in the medical science. Because the sacrifice and the zeal to serve, ardent desire to serve the nation has been so scintillating in his personality. And we once again say, let us give standing ovation to him.
Actually, all of us should think very deeply in their thought, culture, and other things. And the way we have about 23 geographical zones in our country, and 53 or more types of ethnic varieties of people having different expectations. And then multiplicity of the political opinion also is a danger for us, because everything which is done is analyzed so deeply and differently that consensus is very difficult to achieve. But what remains for us as professionals, Indian citizens, is some service to the country. Kennedy once said that do not think what the country does for you, but what you are doing for your country. So that means a certain degree of responsibility which comes to us. And I thank him for highlighting these issues, that all of us together have something much more beyond what we are doing routinely in our lives. Anybody else would like to say something before we do close this session? But the message is very clear. We have to outdo what we are doing.
Another message which Dr. Reddy has given is humility increases with knowledge, and the knowledge has greater value in its utility to the underprivileged and the poor. So the national scenery that we got in an updated session like this on centenary celebrations of my late professor is concentrate on underprivileged, because still mosquitoes are bothering, still the infections are devastating, and then the financial bankruptcy is obvious in tackling the problem. I think the humility with which both the speakers came from eminence of a basic research in gastroenterology to a public issue of primary care, secondary care, tertiary care, I want all of us to convey to him he should become the health minister of our country, join the politics as well.
But more important than his directions which he is giving us is our belief in that we can do it. That is much more important. We can do it, and we should not think of problems. Problems are always there, and every problem when it occurs has a solution to it, and we must find the solution to it.
I really can't recall how I misbehaved with Dr. Shantaram that he should be giving me this responsibility.
I would now request the chairpersons to please present a memento to our distinguished orator for today, Dr. Srinath Reddy sir, and honor him. Dr. Satish Rao, please join on the stage, please. Dr. Satish.
We all salute to these two scientists par excellence, and I'm sure all of you are blessing them also.
Please give him a big hand for a wonderful oration.
Professor Srinath Reddy. He really summed up where this field is. And you know, it always amazed me, for someone who is so much embedded in day-to-day complex cardiology care and being the head of the department, to completely switch gears and really embrace a totally new field of public health and reach the pinnacles of that, and now literally driving that mission, not just in our country, but globally. You know, he was just an important member of the Lancet Commission that really told us where we are in the COVID world. And you know, for all of those and much more, I think it is such a pleasure and an honor that you've actually come and really gave this wonderful oration. Thank you, Srinath.
Thank you, sir. We now conclude this important session of the oration. I now request all of you to join us for lunch, and then we get back with our post-lunch session at sharp 2.
Our speaker who is going to start the session today is a good friend, Dr. Sunita Narreddy, the head of infectious diseases at Apollo over here, a wonderful clinician, a great teacher, and she has trained a lot of infectious disease clinicians now. She heads a fellowship program here. She is going to talk to us about the COVID-19 odyssey, from the trenches to vaccines to pills and everything else.
Thank you, Vijay. I'd like to thank Dr. Satish Rao, Dr. Srirang, and the team, organizing team, for inviting me for this session, which is having most of the big people of Hyderabad, clinicians in Hyderabad. So it's indeed an honor to be here. Thank you. Okay. Vijay, can you just tell me 5 minutes before my time? So today I've been asked to talk about COVID-19, the odyssey of what happened in 20 minutes. So we'll just walk through and see what we know, and more importantly, what we should learn from here. Okay. Okay. So as we all know, COVID is a coronavirus. The coronavirus is the most common virus that causes respiratory illness in one of the commonest respiratory illnesses in all adults, all human beings. And we've had multiple other coronaviruses in the past, including SARS-CoV-1, MERS, and a bunch of others. And what we are seeing now is the SARS-CoV-2, which started off in 2019 November. And if you could it's most likely a mixture of viruses that was going between animals that came onto humans. So it's another zoonotic infection, like we see in most of the infections. The bugs come to humans from animals. So, and we all share We initially had it from bats to humans, and then from humans it goes through other animals, like we've had SARS-CoV-2 infections in tigers, dogs, a bunch of other animals, and then it comes back to us. And this is something that we see all the time with most of the viruses, be it the H1N1 pandemic that we faced, where it was an amalgamation of multiple viruses from birds and pigs and so on. Similarly, that's what we see in here as well. And the strains also, as we know, we can never beat. One thing that we have to remember is there is no way humans can get control of bugs. Bugs predominate in the world, and we will have to learn to deal with them. So likewise, here we've seen multiple different strains of the viruses, of the SARS-CoV-2 virus, starting with the wild type, the alpha, beta, delta, which was a big problem, and then now with Omicron, and multiple other viruses that have happened throughout the last couple of years. So if, again, another pictorial to show the same thing with the change of different viruses, and what we're seeing now is different variants of Omicron currently. And that means it's, our treatment options are also going to change. And is it something universal, or is it specific to a country? Here I've shown pictures of various countries from South America to Asia to Europe, Africa, and you can see a similar pattern in most of the countries, slight variations, but similar pattern. Again, this is partly because of the virus itself, and partly because humans travel. Our globe travel has increased so much that we just take the bugs with us from one place to the other. We've seen other infections as well, as Nipah or Zika or Ebola. The bugs go from one continent to the other, and that's part of what the development and travel has done to humankind. Okay, so the first time that we've heard about a problem that occurred was in November 2019, when there were reports of some illness related to a novel coronavirus in China. Subsequently, they did declare that by the end of December that they were having a major outbreak. WHO realized that they accepted there is a problem in early January, and then gave then we got the virus itself. The whole genome sequencing was done, and we were able to get the virus as well for research for the vaccines as well very shortly thereafter. And that was a huge achievement as far as this the management went by. Initially, we thought it was just an upper respiratory illness, and then we realized that it's much more than an upper respiratory illness. The first couple of months, we said, okay, what's big deal? It's another coronavirus. But eventually, we learned that it's a lot more, and we are now seeing the effects of COVID long term, and that's something that we failed to realize in the beginning. The long COVID is one of the issues that we probably overlooked. And one of the other things that, like Dr. Srinath was telling, infections and communicable and non-communicable diseases overlap. What COVID has brought to limelight is that post-COVID infection, we are seeing a lot of other problems like cardiovascular disease or strokes or other problems. And what we have not observed, which was already existent, is that most infections, be it viral or bacterial, if you look at the 1-year mortality subsequently, you do see a higher mortality because of the post-infectious inflammatory state. You do see higher amount of cardiovascular disease, be it myocardial infarction or strokes, has been noted, which is being more people are aware of this now, though it was there before. Okay. So this is a timeline that of the pandemic that went from one continent to the other. By March, we had a lockdown in place. I think March 2nd, 2020 was the first case of COVID that we saw in Hyderabad. And immediately, shortly thereafter, within the same week or two, the government infrastructure also was working a lot on this. And the good thing there was everybody were involved in the management in terms of creating guidelines, in terms of creating protocols, in terms of what to do further, how to manage. I was also part of that protocol. I think Dr. Shankar is not here. We all worked together in terms of helping the government make the right decisions in terms of what needs to be done. That is one thing that COVID has taught us in terms of working together. And about March 22nd, 2020 is when, after which the opening up happened. So when they opened up and people were traveling back to their own places, we saw the humongous fallout that happened, and the virus was, which was in certain pockets, now went into multiple other areas as well. Now, one thing that I have to, my personal observation at that point was, the rest of the country was in a strict lockdown. Telangana was not in a strict lockdown at that point. I don't know how many of you all remember that. We were an exception from the rest of the country. So to me, it was like almost a real-life case control study where we were absolutely not following lockdown. The rest of the country was following a strict lockdown in that. But basically, again, this is, really can't say. So this is again the timeline of what was happening throughout the world over the next 1 year. And yeah, so one of the major things that came up right after that is, one, the vaccine production started immediately. There was a huge work from multiple parts, in multiple parts of the country and the world in terms of creating the vaccine. There was, and as well as in terms of medications, what medications to give. Solidarity trial was the first. Earlier, we used to meet, IRB used to meet once a month. Here, if we had a protocol, we had to meet immediately, almost on a day-to-day basis. We were meeting to go through protocols to approve. And similarly, the Solidarity trial, which came on first, through a lot of, gave us a lot of information subsequently. But what also came out of that was the huge infodemic that happened, where there was all the information that was being available is there in WhatsApp, and it was a WhatsApp university that was going on. And there was no peer review of any of the research that was happening. If there's a product being researched, that became the standard of care in the clinical practice, which was something that, again, in terms of what we have learned, probably we need to rethink the strategy next time we have a problem like this. We started off with HCQ, lopinavir, ritonavir, ivermectin, all of them went down the drain. Convalescent plasma was like the thing for a couple of days. Anybody that had COVID, you were running around for plasma. Then we proved that it's really not going to make a difference. So it was like whatever you want to do a research on was becoming mainstream care. So we had to be a little bit more careful in terms of understanding the outcomes of the research before we put it into real practice. You can do it on a research protocol, but giving the treatment itself was a little bit dangerous. The one good thing that we got up with that is probably most of the country, we don't have to worry about deworming. Most people are probably worm-free right now, and our anemia rates may go down. So, yeah. So, remdesivir was one of the drugs that eventually stood through the trials, and it is a drug that was previously used for the SARS-CoV as well as the MERS, and the standard dosage of 200 milligrams followed by 100 milligrams. However, initially we were giving it only for giving it for 5 days for people who had moderate disease. Then we thought then the research has also told us that it can be given for people who are at high risk of development of complications for a 3-day period. And again, we were seeing the side effects of the medications as well, so we don't want to abuse these drugs. And okay. Then WHO recently came out with this guidelines, live guidelines. This is something that you probably should all look at, even if it is not for COVID. The way that guidelines presentation has changed such that you can get information at your fingertips comparing whatever category that you want. I can compare remdesivir with molnupiravir and nirmatrelvir. I can compare the various live guideline that has come up, and I would encourage all of you to look at that. So in terms of remdesivir, the final word is that it is a weak recommendation, and it is recommended for those who are at highest risk of hospitalization. So anyone who is at high risk, you can give it. But we also now know that most people don't even bother in terms of, okay, I have COVID, let's move on with life. So the recommendations really are not affecting, changing our clinical practice significantly, I think. Okay. Then the other drugs that we've had included molnupiravir, which is an oral formulation which is more convenient. But again, there's a concern with molnupiravir regarding in terms of teratogenicity, which was a major concern. But it can potentially be used again for the people who are at high risk for developing complications, and it is a weak recommendation. The other drug that antiviral that came and did not stand the trial is favipiravir, which is no longer used. Nirmatrelvir ritonavir combination is Paxlovid. This seems to work reasonably better than remdesivir and molnupiravir when you compare the two drugs. The major disadvantage with Paxlovid is that you have to worry a lot about drug interactions, and you also have to make sure that you screen them for HIV, because if by chance they have HIV, then you're risking development of resistance to protease inhibitors. So that's something that has to be remembered. This is a strong recommendation for use in patients who are at high risk for developing complications. Oh, thank you. So, then when it comes to the JAK inhibitors, we have the baricitinib, which is a strong recommendation. Baricitinib was used a lot in this country even before, thanks to the drug being available freely. Actually has come out that you can even use combination of baricitinib as well as tocilizumab together, which I'm very, very skeptical about because of the increased immunosuppression. Steroids was a big thing. At one time, people were getting like 250 milligrams Solumedrol 3 times a day for mild or asymptomatic COVID. And that was a huge no-no. In fact, it came even to our government guidelines. Telangana government guidelines also brought out the Dexa 8mg. Dr. Raja, we remember we discussed about it. We debated a lot about it, and I'm not sure how it landed up there. But anyways, another lesson, you can't just keep abusing drugs. You need to know what the side effects are, and you need to be extremely cautious. Steroids are excellent drugs, but come with side effects. So you need to be very careful when you use these drugs. Interferons were talked about, but did not stand the trial. Monoclonal antibodies, again, we had the Lilly product, and that did not work very well. And okay, fluvoxamine was a no-no. Convalescent plasma was a no-no. Ivermectin, no. Colchicine was again given a lot for a lot of people, not recommended. Casirivimab, imdimivab, and sotrovimab were used for the earlier ones. Now we are saying that it's probably not going to work because of the resistance that is developed with the newer Omicron. And vaccines, there are several different ways that you can create a vaccine, be it a subunit vaccine, RNA vaccine, DNA vaccine. And this technology has transformed so much, particularly the mRNA vaccine. I'm hoping that that will also shed light, and we will get more vaccines for more infections, particularly HIV, for which vaccine is long overdue. One of the major issues with vaccines we've seen is the unequitable distribution of the vaccine in certain countries, where the underdeveloped countries were not having enough stock, whereas the countries that were making the vaccine had were able to vaccinate more of their population. And that leads us to the next public health concern, that there's no point taking care of only your population. Unless you take care of the entire world, you're not going to be able to fight these problems. So a learning point for all of us in this again. Okay. So these are the vaccines that are currently available in the world. And the various policies in terms of how the vaccines were rolled out, initially for the high-risk people and then subsequently for everybody else. Now we have recently the newer vaccines that we have are the Cobivax, Covaxin and Zycov-D, all of which have been approved by Government of India, still awaiting WHO approval, I believe. Okay. See, this is the unequitable distribution of the vaccines. As you can see, the African continent is really low in terms of the vaccine outreach. Okay. So major things that we've learned. So it's COVID was made it very clear that we have a public health issue, and any health issue, public health issue, is also connected to economic recovery. And so as much as we need healthcare workers, we also need to understand the economics of health as well. And thanks to people like Dr. Srinath Reddy and PHFI, we are learning a little bit more in that area as well. And antiviral development, we need to work more on this. We need to improve our infrastructure, health infrastructure. None of this, I mean, during this, I think January 2020, before the last major epidemic spurt of cases that we had, there were a bunch of ventilators lying in various hospitals because the hospitals were all flooded with ventilators or BiPAP machines, and they were sitting in cupboards and in rooms locked up because they were never used. And when the number of cases started to increase in March of 2020, there were machines, and we did not even do a troubleshooting on them. We were not using them, and so though you had machines, you were not in a position to use them. You need to have a better infrastructure, health infrastructure. You can't keep switching on and switching off. So the health infrastructure across the country has to be developed, and this is one of the lacunae that was observed in COVID. I hope we improve, but I'm worried it's going back again to the older days. Whatever infrastructure that has been, whatever investment that has been put into the infrastructure, I hope is not going down the drain. So a lot of lessons that we've learned in terms of not using drugs unless you know that they are useful, because otherwise you're just abusing drugs. People were buying remdesivir for 1 to 1.5 lakhs at certain times. That was a panic reaction. We need to figure out how to, for the next time around we have this problem, we need to figure out how to contain the fear factor also. Again, Hyderabad was fortunate because we had a surplus of beds, but most of the country we had issues as well. Okay. And so antivirals, other thing is we need to use them early in the course of the disease, not later in the course of the disease. Okay. So with that, I will stop here.
Thank you very much, Dr. Sunita, for that overview. She finished her MD from PGI Chandigarh in 1996. Then she joined our department. She came to me initially regarding HIV, and then she took interest in ID, HIV medicine, and adult vaccination. She was very helpful during the scrub outbreak, dengue outbreak, chikungunya, and swine flu, and even melioidosis. She has got a lot of interest in publications. She's got 50 publications and 50 talks in a national and state level. One of the most prestigious work she is doing now is ICMR Network for Antimicrobial Stewardship. That's what she's doing, and contributed to chapters of ICMR. So, Dr. Subbalakshmi, she'll be talking about infectious diseases in 2022, what is new?
Thank you, Srirang, also for inviting me. So when Dr. Satish has given me this topic of infectious diseases, what is new, then I thought I will look up for something what is relevant to India, so that I can communicate to the students and the audience who are coming here, than just to speak on something which I do not see in the department. And then I thought, what is bothering India right now, after COVID, and right now is tuberculosis. So let me share some experience on this topic on tuberculosis and how it is moving forward and what is new in the management of tuberculosis. So every year we see around 10 million people worldwide diagnosed with tuberculosis, and India has a lion's share in that. And an estimated 1.5 million people die from the disease, and so is the case with India. So the WHO recently revised the definition of they've changed some of the definitions. So what is new in the programmatic management of the drug-resistant tuberculosis? Now we are not talking about the drug-sensitive tuberculosis anymore, because the number of drug-resistant tuberculosis is increasing. So what is new in the PMDT 2021 and 22? It is a change in the definition of drug-resistant tuberculosis, and the universal drug susceptibility testing for all people, all the patients with tuberculosis, and shorter oral bedaquiline regimen. Those are the physicians managing patients with tuberculosis, and those managing the difficult TB, they know that difficulty while managing. Sometimes the patients have to go through the treatment which is not so beautifully effective for about 2 years and tolerate all the side effects. And then now they are bringing shorter oral bedaquiline regimen and combined use of bedaquiline and delaminate and TB preventive therapy, even for the DRTB TB cases, because this is even more important. And bedaquiline in pediatric age group and implementation of DRTB services in private sector. So this update was based on the evidence that high effectiveness of levofloxacin, moxifloxacin, bedaquiline, and linezolid in drug-resistant tuberculosis has led to this new update in the PMDT. And this is one of the papers which, the usual reason for the drug resistance is because in tuberculosis, because people are not completing 6 months of their, even if it is a drug sensitive tuberculosis, 6 months of treatment also they are not completing. So there is an attempt to see if the duration can be brought down to 4 months. So in this trial, what they have done is, the standard treatment of HRZD was compared against rifampicin and INH, moxifloxacin, and PZA in one arm. The other arm, they tried rifampicin with INH, with ethambutol, with PZA for 4 months. So here we are reducing the treatment by about 2 months, but I do not think this will stand the test of time, because you're introducing moxifloxacin right at the beginning. So this is about this paper. And then, as per the National Drug Resistance Survey released in 2018, only 44% of the estimated MDR-TB cases are diagnosed and 56 remain untreated. So the increasing burden of DRTB has led to the rapid expansion of programmatic management of tuberculosis in our country, and pre-XDR TB is now introduced. It is a new term. Previously, there was sensitive TB, IN, and then MDR TB. But now they have introduced a new term called as pre-XDR TB, which says that TB bacilli, which are resistant to INH, rifampicin, and fluoroquinolone, they are called as pre-XDR tuberculosis, and the XDR tuberculosis is redefined now as Mycobacterium tuberculosis bacilli, which are resistant to INH, rifampicin, and fluoroquinolone, also resistant to bedaquiline and linezolid. So the XDR tuberculosis definition is changing. I think many of us, the physicians are managing patients with tuberculosis, and I think the definitions are changing, and we should know microbiological diagnosis and on the molecular diagnosis, and we should know about all these things. So during your MD, you should know about the diagnosis of tuberculosis very well. And we have a lot of postgraduate students, so I'm addressing some of the points to them. And we should have a clarity in the diagnosis, and we should know about the new modalities that are that are there. So we already know that expert TB for rifampicin resistance, it is very helpful. Then now there are other tests like TrueNat, line probe assay, then culture methods also. So the CBNAT is a cartridge-based test. I think it is there for the last 15 years, and it will detect MTB, and also it will diagnose the rifampicin resistance. And an advanced version of CBNAT, which can detect the resistance against INH, fluoroquinolones, and second-line injectable drugs and ethionamide is being developed. And PMDT 2021 is aiming to progressively introduce these modalities. And expert TB expertise will not only reduce the turnaround time, but it will also reduce the burden on the LPA machines. And the TrueNat is a chip-based test, and everybody knows about this test during this COVID. Is extensively used and is being used even for the diagnosis of tuberculosis. And the phenotypic drug sensitivity is available for rifampicin, INH, PZA, fluoroquinolone, and second-line injectable drugs, and now they are trying to expand it to the clofazimine also. So the DRTB drugs were classified into 5 categories earlier. Now they are classified into 3 categories, A, B, C. So when you are constructing a regimen for a drug-resistant tuberculosis, so you should know about this, the classification, and then construct the regimen. So now the resistant tuberculosis, the rifampicin-resistant tuberculosis now involves the treatment with bedaquiline, and the bedaquiline is not available over the counter. So once you have a drug-sensitive tuberculosis, you need to inform the authorities, and after that you are free to start the tuberculosis treatment. But once the patient develops rifampicin resistance, then the patient should be referred to a government center wherein they will have the benefit of bedaquiline-based regimen. So coming to the treatment of the drug-resistant tuberculosis, the INH, if a patient has got a INH hypersensitivity or monoresistance, the treatment is replaced, INH is being replaced with the levofloxacin. But if it is an MDR tuberculosis, then treatment is for about 9 months to 24 months. So, and if it is an extensive disease, then the treatment is for, even longer, up to 2 years. Okay, so coming to the drug-resistant tuberculosis further, because this is the burden that we are all, facing, and currently the recommended regimens are 9 to 24 months duration, and in recent individual patient analysis, the outcome of the pulmonary resistant tuberculosis is only 61%, despite tolerating all these side effects, and despite giving prolonged treatment, the outcome, the success rate is only up to 61%. So this in turn fuels the drug-resistant tuberculosis to spread, in the society. So a shorter, less toxic, more efficacious regimen is the need of the hour. So the development of a highly effective oral 6-month regimen for the treatment of multi-drug resistant tuberculosis, which previously took 18 to 20 months to cure, is one of the defining achievements of tuberculosis research and community in this century. So during that search, so there was a trial which was conducted in Africa on 109 patients, wherein they have used bedaquiline, pretomanid, and linezolid 1200 milligrams, and they could achieve 90% of good outcome in a duration of 6 months. So the efficacy of the regimen has come with a cost with high side effects. So then come the, this is the same representation of the same thing which the next trial which I have just described. In the XDR tuberculosis, the outcome, the good outcome was to the tune of 89%. In the MDR tuberculosis, it crossed 90%, up to 92%. So next comes the Xenix trial, wherein they try to look at the same drugs, but with a less, and what is the ideal duration and what is the ideal dose of linozolid that can be used in this population. Here in this trial, there were 4 arms, wherein 1200 milligrams of linozolid is used for 26 weeks and for 9 weeks, and then 600 milligrams was used for 26 weeks and 9 weeks, and then looking at the outcome, they have come to the conclusion that the bedaquiline with pretomanid with 600 milligrams of linozolid for 26 weeks has a favorable outcome. So, with the same medication, that is with the bedaquiline, pretomanid, in rifampicin-resistant tuberculosis, there was one more trial that was going on that was called as TB Practial trial, and it was tried in 3 countries. It was, there were 4 arms in this. The standard treatment for the resistant tuberculosis, which is about 9 to 24 months, compared with the bedaquiline pretomanid based regimen with linozolid. Then it was also combined, another arm was added wherein the moxifloxacin was added, and in another arm they have added the clofazimine. And these results were handed over to the WHO, and there is a rapid communication from the WHO to the rest of the world. So then comes the next trial. So wherein this is an all-oral 6 months regimen for MDR tuberculosis. It's a multi-center randomized controlled trial. So again, they were using the same drugs, and these trials are also have led to the next rapid communication from WHO, wherein they precipitated by the Xenix trial and the next trial and the Practial trial, wherein they say that the future is going to be for the management of MDR tuberculosis, for rifampicin-resistant tuberculosis, it is going to be 6 months of bedaquiline with pretomanid with moxifloxacin, including linozolid. So for about 600 milligrams per day, may be used in place of longer regimens, which are for about 24 months. If you're really managing a patient with MDR tuberculosis, we will know the difficulty the patient undergoes. Most of these patients are all, most of them are immunocompromised. Some of them are SLE patients, wherein in Africa, they have done a screening echocardiogram on all children, and they found out a certain population, a certain percentage of people having a latent rheumatic heart disease. And they have divided them into 2 groups, wherein one group was given the penicillin prophylaxis, other group was not given penicillin prophylaxis. And those who received penicillin prophylaxis have, reduced progression of the chronic rheumatic heart disease. Why I chose this paper is because in India we are still having, getting to see a lot of cases of chronic rheumatic heart disease, despite so many antibiotics being used and especially being misused, but we still continue to see chronic rheumatic heart disease patients. So this is a paper, many of us treating HIV, we know the difficulty in procuring the flucytosine and the toxicity of, administering patients with amphotericin conventional, and also prolonging the treatment, and also experiencing immune reconstitution in these patients. So with all this paper highlights the single dose of amphotericin in patients with cryptococcal meningitis has got very good effect along with flucytosine and fluconazole, and with least number of side effects. This paper I cannot believe, unless maybe we see, and being administered in some of our patients, because usually the patients that we treat are all very sick and very moribund. So this is one very important paper wherein we have all seen a lot of mucormycosis in post-COVID, and the diagnosis gets delayed. And the mucormycosis we get to see even in patients with post-chemotherapy also. And the diagnosis gets delayed because the patients are sometimes hooked to ventilator, sometimes they have thrombocytopenia. You won't be able to get the sample, you won't be able to do the bronchoscopy, you won't be able to do the CT-guided biopsy, all these things, and you don't get a material. You'll be treating them empirically. So this paper says a serum PCR diagnosis for mucar DNA will will enhance the diagnosis, will prepone the diagnosis, and will help the patient and also the clinician in diagnosing early and start treating early. So this is called as a Modi mucar study. And this is another population-based study because we have a lot of dengue fever in this region, and wherein the Wolbachia infected mosquito deployment, it was controlling dengue fever. This was done in Brazil. So the intervention cluster had less number of cases and less hospitalizations. So I don't know whether it can be extrapolated to our country, because right now we are actually having lots of cases and also very sick cases of dengue fever. And this is another paper, the infectious disease is not complete as far as the India is relevant without malaria. So the malaria number has significantly come down in the last 25 years. When I was a resident, every day, every night in the night duty, we used to see 3 to 4 cases and used to declare, despite administration of quinine, with so much of hypoglycemia, lots of side effects, QT interval prolongation, all these things. But now, with the advent of artesunate combination therapy, in my own lifetime, I could see the number of cases of malaria coming down in the region, and also, it's a beautiful experience. Also added to that is the addition of the rapid diagnostic tests for the malaria has reduced the number. But sometimes you do get cases of malaria on and off in our institute, and Plasmodium vivax and the relapses are quite common. So how to control that? So they have tried one observed usual treatment with primaquine with a double dose of the primaquine treatment, and they found out the double dose and increased duration has reduced the number of relapses in patients with Plasmodium vivax. Thank you.
Thank you very much.
And also to Dr. Subbalakshmi, thank you very much for your presentation. Thank you. So Sunita, I had a quick question.
I'm not eloquent enough to explain that. But I think there's one major pathogen, the others had come down, the others are coming up now, and people are falling sicker for longer duration. Dengue people with fever for 10 days I've not seen before. We'll start looking for other causes. Here I'm seeing everything now. Yeah, it's been interesting the last couple of months.
Yeah, this one disease increasing and other coming down, I have seen with, dengue and chikungunya. So the year when the chikungunya was very high, the dengue was less. So the explanation that I got from some of these DRDO people with whom our people have interacted on the diagnostic and on the LAMP study and all that. So what they have told is that it is something called viral interference. But I don't know what happens, if when they are not sharing the same vector.
Sir?
Any other questions?
Yeah, sir.
It's open to the House.
So this is Dr. Jagdish. Madam, I similarly had the same question, which of last decade we never seen any case beyond 7 days of fever. But this time maybe, as you told, it is immunosenescence. Actually, we coined a term like post-viral immune dysregulation syndrome. Your immunity has, it has triggered a lower threshold. For every subsequent infection, things are out of hands and which we can't explain. The other thing is, Vijay sir is here. I think 2 years back we have done a conference in AIG, and he has introduced colchicine and inflammasome concept. Are we still holding on colchicine as one of the drug of choice in these viral fevers?
See, the accumulated evidence about colchicine is that it early infection. What seems to be working much better, and I've seen some data which is unpublished, is inhaled budesonide. In fact, if you start inhaled budesonide within 48 hours of symptomatology, the symptoms completely disappear. I've not had anybody hospitalized so far this season who had started inhaled budesonide within 48 hours. The colchicine story is interesting in some other ways. There is a subset of people who have what we call thromboinflammation of the blood vessels. And in those people, maybe that the colchicine will have a role. I think what we need is much better, much longer studies that look at things that are good markers of vascular inflammation. For example, factor VIII levels or other markers of vascular inflammation. What we have seen this particular wave is several people presenting with mesenteric thrombosis, and we've had, unfortunately, bad outcomes. So I think that in COVID, it's very heterogeneous. You have to decide by accurate phenotyping exactly what syndrome you're looking at. Are you looking at simply a macrophage activation syndrome? Are you looking at thromboinflammation? Are you looking at combinations? Or are you simply looking at a lot of cytokines that just make people feel terrible?
Okay. So, Madam, regarding remdesivir, who are included in the study are always beyond 5 days or 7 days of the disease. And whereas in our setup, most of the times it was like prophylactic admissions. People, the moment they have a positive report, they come to the hospital. We have given remdesivir significantly. We have seen a serious amount of improvement. So, do you agree with that?
See, in our centers, like I agree with you, both our centers at least, most of the people who, biggest challenge that I found thanks to COVID is that, actually a couple of things. One, TB took a huge beating. So going forward, you're going to have a huge problem with TB. Two, a lot of money from CSR has been diverted to medical reasons for the last 2-3 years. And now getting any funding for any medically related project is going to be a huge challenge. So other issues in terms of infections like TB and malaria and HIV are going to have a huge uphill battle trying to get back into their work.
Normal, and if they're immunocompromised, I feel that it is still useful, and I just now admitted one, 3-4 days ago, and then we have given it, and we need to use our discretion and use it. Exactly. You have a lot of experience, and you have a lot of publications also on COVID. And again, regarding the question of this dengue fever, the fever going on beyond 7 days. So I have seen it from the last 10 years like that. There is a small subset who would go on beyond the usual 7 days, or usually by day 6 the fever should break. And if the fever is going beyond, means most of these patients whom we have again did a workup, and we found that they are bacteremic. The bacteremia is because of some time during this course of 7 days, they had gone into hypotension. So when they have gone to the hypotension, so there is a transmigration of the gut bacteria. And if you see all of these people, they have got gram-negative infections. So either it is nosocomially acquired very easily because of the immune senescence or whatever, or their own bacteria which are going into the body and then causing sepsis and then not doing very well. So if you do the procalcitonin, I think in some percentage you see that they are going into bacterial sepsis. This is the time when we have to give the antibiotic, not early. I know you know all these things. Yeah.
One last comment by Dr. Vijay, please.
Sir, I'm yet to be convinced that antivirals have any role in COVID. So if you can convince me, I'll use it in my patients.
I have a small question. Actually, I'm Dr. Vikram. I'm practicing in primary care setups with 2 clinics.
I'm sorry.
So, sir.
Loud and clear.
Yes, sir. I'm Dr. Vikram. I'm practicing in primary care setups and not wanted to understand from the experts here. So, reinfection rate, acute undifferentiated fevers are the common these days, and convincing is apart, but the dolo is not working. Every 3rd hourly we got to pop in pills with dolo. Sometimes naproxen is working, sometimes mefenamic acid is working, we are giving, and this became a very common primary care setup problem. So can you please guide us regarding this?
Maybe is it dengue? So we have got rapid diagnostic test for dengue fever. That is the NS1, which is rapid, and also there is a ELISA to confirm that. And then there's a lot of, we should know how to interpret the reports, on which day of fever the patient is coming, and when the NS1 is coming positive, when the IgM is coming positive. So if the IgM is positive and NS1 is negative on day 3, that means it is most probably not dengue fever, something else. So what is the next fever that is very prevalent in our region? It is the scrub typhus. If the patient is coming from a rural background, or he has got a garden in his house, that it is most probably maybe because of scrub typhus. The diagnostic test is IgM, but it won't be positive in all patients. Okay, so how to how to confirm? Okay, so you look at the LFTs. Do not invest the money on Vidal. Invest on the invest on LFT. You get a clue. So I think what is prevalent here is the scrub typhus. I think we need to look at it. And the next common thing is typhoid. So you try to diagnose, then you will have a clarity.
I do. Thank you, Dr. Subbulakshmi. Thank you, Dr. Vijay.
Randy. We now move on to the next session, and that is on pulmonology. For this,
from Apollo Hospital, Dr. Ajit Vik, to tell about bronchial asthma. Over to Dr. Ajit Vik.
Respected chairpersons and dear colleagues, at the outset I would like to thank Satish for to give this talk on asthma, and I am also grateful to the members of the organizing committee of API for inviting me to give this talk. It is indeed a great pleasure and an honor to deliver this talk to this knowledgeable audience. There are a lot of new things happening in the management of asthma, and my task today would be to make sure that we understand what's happening in the field of asthma. Can you just show me? Okay. My task today would be to touch upon these various aspects on asthma. First is about the goals of treatment, the various phenotypes of asthma which have been identified in the last 1 decade, and touch upon the newer techniques for diagnosis vis-a-vis the traditional method of diagnosing asthma, and then the treatment approaches of controller versus reliever, or a single maintenance and reliever therapy, the so-called popular SMART therapy. There are several new kits on the block, and I would like to spend a few minutes, if time permits, to talk about anti-IL-5 therapy, mepolizumab, breslizumab, and benralizumab. There is also anti-IL-4 R therapy, the dupilumab, and we will talk about it if time permits. Lastly, how COVID has impacted our understanding of asthma, we need to know, and how our concept of treating asthma with nebulization has radically been changed in the last 3 years. So let's look at what is our goal of treating asthma. It is extremely important to recognize that we optimize the control of asthma symptoms, and this is important because we would like to reduce the future risk of acute exacerbations, because one should understand that each exacerbation is associated with progressive decline in lung function, particularly in the adult population. Whereas in the pediatric subgroup of patients, if you don't control these exacerbations, it will lead to suboptimal lung development, and they will therefore be respiratory cripples for the rest of their life. So I think it's extremely important to make sure that we control these exacerbations and optimize the treatment by and large in all set of patients. Also, like any other chronic disease, adverse effects from anti-asthmatic medication needs to be looked at. There is a lot of talk about asthma phenotypes in the last 1 decade, and this is important to recognize and identify who are these subtype of asthma patients, because we can tailor specific therapeutic agents for these asthma phenotypes. So let us look at the various phenotypes of asthma which we encounter daily in our clinical practice. One of the common asthma phenotype is the one with frequent exacerbations. So these are the group of patients who keep coming into the emergency room, who keep getting admitted again and again, at least 2 or 3 times in a year. These are characterized by higher peripheral airway obstruction. So they have marked obstruction of the airways in the peripheral airways. They have persistent eosinophilia both in the blood and in the bronchoalveolar lavage specimens. And they are less likely to be atopic, and these are the group of patients who require really very aggressive therapy. So they require high dose of inhaled corticosteroids, they require LABAs, long-acting beta-2 agonists, they require also their montelukast and oral theophylline on a regular basis. And these are the subgroup of patients who probably will also benefit from the biologics, of which I'm going to talk to you a little later. There is this another subtype of asthma population which we come across, and these are called as the hypereosinophilic adult onset type of asthma patient with aspirin exacerbated respiratory disease. We have all heard that aspirin sensitizes these group of patients, and they are less likely to be atopic. They have high levels of both blood and tissue eosinophils. They have high levels of fraction exhaled nitric oxide. They are associated with several other upper respiratory tract comorbidities like chronic sinusitis, nasal polyps, and aspirin exacerbated respiratory disease. The primary reason why these people react so abnormally is because of the total dysregulation of arachidonic acid metabolism with overproduction of leukotrienes, which leads to bronchoconstriction. And they are the subgroup of patients who will respond to your anti-IL-5 directed therapy. So either mepolizumab or reslizumab would be the drug of choice for these subset of patients. So if we can understand and identify this special variety, they will definitely be benefited with these new drugs which have been totally revolutionized our approach and treatment of asthma in this subgroup of patients. The other asthma phenotype which we commonly see in our clinical practice is the one with morbid obesity. Here, these are the group of patients who have a body mass index of more than 30 kilogram per square meter. They belong to about at least 1/3 of the total asthma population. More in females in their late 30s or early 40s. They are usually non-atopic and often associated with metabolic syndrome and high levels of circulating IL-6 levels. One more asthma phenotype which we must understand, which is highly controversial, is the so-called neutrophilic asthma. Specificity of neutrophilic inflammation is compounded by several factors. The previous use of inhaled corticosteroids themselves may trigger neutrophilic response. The associated surrounding air pollution, the frequent respiratory infections with these subgroup of patients have, and also sensitization to the aspergillus may be responsible for the neutrophilia. So therefore, the very existence of this subphenotype is not well recognized. However, it is known that these subgroup of patients have persistent airflow limitation, and therefore they are very, very difficult to be treated in general. The last asthma phenotype is the most common one which we come across. Almost about 2/3 of severe asthma patients belong to this category, the adult onset disease, and they are associated with persistent elevation of markers of type 2 inflammation, so high eosinophils, high fractionated exhaled nitric oxide levels, high levels of cytokines IL-4, IL-5, and IL-13, and they are more in adult population than in the childhood. Targeted therapy again is with monoclonal antibodies to IL-5, very, very useful. So mepolizumab, reslizumab probably will play a role in these subgroup of patients. So having recognized the various phenotypes, let us look at how do we do the diagnosis in the year 2022. Although spirometry continues to remain the gold standard, wherein we would document it as an FEV1 less than 80% of predicted normal to label it as asthma, and an FEV1 FVC ratio less than 70% or below 5th percentile lower limit of normal, which has been very clearly defined by the task force technical statement published about 3 years ago. And based on this, we normally diagnose asthma. Importantly, as part of the diagnostic workup, we need to document that after giving inhaled salbutamol, there is an increase in FEV1 of more than 12% or more than 200 ml over the baseline. However, if the diagnosis is still not clear, then one should go in for expiratory spirometry, considering flow volume loops for diagnosing asthma. There are several new techniques which have come up, and I will talk to you about both of them. Fortunately, both of them are now available in our country and in our local state as well. The fraction of exhaled nitric oxide I'll first talk to you about. And airway inflammation in asthma leads to high levels of nitric oxide in the exhaled breath, and this is expressed as fraction of exhaled nitric oxide. Importantly, it returns to normal levels after the inhaled corticosteroid treatment. It's a very useful technique because it is non-invasive, can be performed repeatedly, useful both in children and in adults, particularly elderly patients with severe airway obstruction where routine PFT is often very difficult to perform. Highly sensitive for detection of eosinophilic airway inflammation, and the recent ATS and the ERS statement confirms that fraction of exhaled nitric oxide should be used for monitoring underlying airway inflammation. It's an important marker to monitor airway inflammation, and any value of more than 50 particles per breath suggests that there is an underlying eosinophilic inflammation going on. Useful for predicting treatment response, plays also a very significant role in monitoring adherence to inhaled corticosteroids. So if the patient defaults from his regular use of inhaled corticosteroids, one can identify if the FeNO levels go up. So therefore, it is very, very useful in overall management of asthma. It's cost effective for diagnosis both in children and adults. However, there are certain current limitations, because if the patient has concomitant allergic rhinitis or other atopic conditions, one may have skewed reports with FeNO, and therefore one has to take it with a pinch of salt. The other new technique for diagnosing asthma is the impulse oscillometry, and let us briefly talk about that. It's a forced oscillation technique, does not require maximal inspiratory effort, useful both in children as well as in elderly population. Clinical endpoints have not always been equivalent to FEV1 because it shows wide variability. Predicted values in large population studies are still underway and have not yet been universally generated. Unfortunately, in our country, the Indian data is currently limited to a very small subset of patients, and large-scale data is still lacking. So I think time alone will tell us how impulse oscillometry will help us in diagnosing, but definitely this is going to be the future for diagnosis of asthma. Let's look at the way we are treating asthma in year 2022. According to the GINA guidelines, it is important that we stepwise approach in the therapy with aggressive attempts to control the symptoms as quickly as possible. Subsequent therapeutic adjustments in a stepwise fashion as symptoms require, and adherence to this guideline-based therapy always helps us in achieving good optimal control of the disease. Therefore, the ideal treatment would be to initiate low-dose inhaled corticosteroid and long-acting beta-2 agonist as a combination. Now, this is in sharp contrast to whatever was being talked about by the GINA guidelines until 2021. 2021, they used to say still salbutamol or terbutaline should be the first line of treatment. But for the first time in 2022, GINA guidelines, they have clearly mentioned that initiate treatment with low dose inhaled corticosteroid and long-acting beta-2 agonist, both budesonide and formoterol, as a maintenance and reliever therapy. And it is extremely important to recognize that start it from step 1, stage 1 of asthma, low intermittent dose of inhaled corticosteroid and formoterol to be initiated for those patients who have step 1 asthma. There are several such combinations available. By and large, budesonide and formoterol has been extensively studied. More than 100,000 patients have been evaluated across both North America, Europe, and Asia Pacific region. There are other combinations such as fluticasone, salmeterol, mometasone, and formoterol, and recently fluticasone, furoate, and vilanterol, which has now been made available in our country and as well. But by and large, budesonide, formoterol, the data is very, very encouraging, and this can be initiated for all our patients in the form of low-dose inhaled corticosteroid and formoterol, and stepwise increase the dose if required. So start off with low-dose inhaled corticosteroid and LABA. If they are still having symptoms, increase the dose of the inhaled corticosteroid. If they still have problem, then you add on leukotriene receptor agent like montelukast and a low dose of slow release theophylline at night time, particularly if they have nocturnal symptoms. If they have associated upper respiratory problems like nasal polyposis or allergic rhinitis, leukotriene receptor antagonists will definitely help. So there's a definite role for montelukast in these subgroup of patients. So stepwise, if we can increase the dose of our available therapeutic regime, it will help us to control the disease by and large in a large way. There are certain evolving concepts considering use of IL-5 and IL-5 receptors antagonists for severe uncontrolled adult eosinophilic asthma, when the blood eosinophil level cutoff point is more than 150 ml to guide the IL-5 initiation. Also, anti-IgE antibodies can be used like omalizumab or mepolizumab. Omalizumab has been available in our country for more than 10-12 years, and we have been using in a select subpopulation with good results. Considering inhaled tiotropium is also a useful option, because inhaled tiotropium will definitely work in those patients who have got nocturnal symptoms despite their combination of inhaled corticosteroid and LABA and low-dose theophylline. So inhaled tiotropium definitely will help if they have got associated nocturnal symptoms. Consider a trial of chronic macrolide therapy, and this is treated with everything available on the board, and yet they are having recurrent symptoms. Then the recommendation are that you should consider chronic macrolide therapy for 6 weeks to 12 weeks. What about biologics? There are several recent reports from the literature to suggest that yes, they are definitely useful in the subgroup of patients. And these are to target specific inflammatory pathways and has radically transformed our overall management of uncontrolled severe asthma. Several studies which I have published here, which I have mentioned here, have shown that asthma exacerbations reduced by more than 2/3 by the regular use of biologics in these subgroup of patients. Lastly, I would like to talk about COVID-19 and its impact on asthma. It is extremely important for all our asthmatic patients to continue all their prescribed regular asthma medication, particularly their inhaled corticosteroids. And we try to tell them to avoid nebulization wherever possible. In fact, last year GINA guidelines vehemently put this on paper, saying that we should avoid routine nebulization because of the danger of dispersal of the viral particles to the healthcare staff and to the other family members if he is taking home nebulization. more likely that asthma patients, if they are uncontrolled, will suffer with COVID-19 complications. And one such study published about 1.5 years ago showed that more than 20% of these asthmatic patients, when they had co-infection with COVID, they required ICU admission. This was in contrast to those patients who had co-infection with COVID in diabetics and co-infection of COVID in cardiovascular disease, where again there was ICU admission in 24% of diabetic patients and 20% of cardiovascular disease. So almost on par with these chronic diseases, asthma patients are probably more prone for a severe outcome of their disease and require ICU admission. So therefore, I think we need to understand that and treat our asthma patients appropriately and optimally. Thank you. To wrap up, to summarize my talk, I've just dealt with the various treatment modalities which are available, and also I've mentioned to you about the new biologicals which are available in the market. Thank you one and all for your patient listening.
Common these days globally, and it's a very complex disease. It's a heterogeneous disease in terms of presentation, and response to treatment is also, it's very heterogeneous. Now we know there are many phenoendotypes, and then there are some useful biomarkers that are very useful both in the diagnosis and management of asthma. We have moved from one-size-fits-all ICS-LABA to personalized medicine in the form of biologics. So thank you very much, Dr. If there are any questions, I think it's open. We'll take it.
He's based at Apollo Hospitals, and he's going to talk to us on the recent advances in bronchoscopy and how it's changing the management of pulmonary disease.
In TB hospital, when we were undergraduates, I remember.
So there is a big list of firsts to his. Yes.
Respected chairpersons, it's really touching that the chairpersons have kind words to say for me. And I take this opportunity to thank Dr. Satish and also the family members of Dr. S.R. Rao and the organizing committee members of API, Scientific Committee. And that's because my father was a classmate of Dr. S.R. Rao in Stanley Medical College, Madras. And surprisingly, before joining MBBS in Stanley Medical College, he went to Nizam College to do his mathematics BA, just like Dr. S.R. Rao. And after BA mathematics, he went into MBBS. And then after completing MBBS, because of the financial pressures, he joined at that time the Nizam's government, and then he was posted as a medical officer in a district hospital. Rao on non-invasive ventilation in respiratory failure, a turning point in medical history. So, it's not moving? Yeah. Then I had to come face to face with the legend, Dr. S.R. Rao. That was when I was doing my MBBS in Kakatiya Medical College, Warangal, in 1975. I was appearing for the final medicine examination, practical exam. I had a patient, and because of my name, Vijay Kumar, alphabetically, my turn came very late. So although I entered the ward in the morning, I had to wait till evening 5 o'clock for the examiner to come to me to examine me. So finally, I was having a very fearful image of Dr. S.R. Rao. So, but when he came, he was very calm and quiet. And then he said, "What is the case?" It was a case of mitral stenosis. And since I had so much of time, I auscultated the patient almost 100 times, mid-diastolic murmur, mitral stenosis, etc. So I was ready. And he said, okay, what is so striking about this patient? Yes, I said, he looks very dark. So what do you call? I said, hyperpigmentation. Okay, what is the first thing that occurs to your mind when you see a hyperpigmentation? Sweating. I said, only one question, that's it. And then he said, go. Then next day, it was time for me to appear for the Viva. He said, Dr. S.R. Rao said, did you hear about glomerulonephritis? I said, yes, sir. Sir, minimal lesion. Then again he said, go. Finish, go. So I didn't know whether I did well or not. But then with 80% in medicine, I passed my MBBS. So that was the way Dr. S.R. Rao used to find out whether somebody has got a depth of knowledge or not. So friends, on the request of Dr. Satish Rao, I narrated a few anecdotes with Dr. S.R. Rao very fondly. And I have witnessed myself the ambidextrous way of writing on the board, the different things on the white blackboard. So coming back to our topic, the recent advances in bronchoscopy and how it is changing the practice of pulmonary medicine. I did my MD from 1977 to 1980. And during my PG in pulmonary medicine, I did not get an opportunity to see a bronchoscope, leave alone touch it. So, but I wanted to get trained in that. There was no internet, there is no way of knowing who is doing the bronchoscopy, who is doing the training. There was no mobile phone in those days. And somehow I came to know that there is somebody who is doing a bronchoscopy in Trivandrum. So in 1985, I took a train to Trivandrum and then stayed right opposite the hospital in a third-rate hospital where many cancer patients were staying there to take their chemotherapy. So Dr. Sashikumaran was the thoracic surgeon who was doing bronchoscopies, not 1 per day, not 2 per day, but he was doing something like 30 per day. But he was doing it on 2 days in a week, Monday and Thursday. He said, you have to stay for 4 weeks to really get a feel of the bronchoscope. So I stayed there for 4 weeks, got trained, and came back to Hyderabad. So the journey begins. But then slowly, there were a lot of things happening in bronchoscopy. So I went and attended different workshops in different countries. In-depth, rigid scopes, how to use different devices, etc. And then when I completed my training over a period of time, I took upon myself the responsibility of training my students and my colleagues in bronchoscopy. So when it comes to the recent by Professor Ikeda, and just to get started, this is a male, 50 years old, who is a diabetic, uncontrolled, comes with fever, loss of appetite, and loss of weight. So looking at the X-ray and looking at the CT scan, one would say, looks like tuberculosis, but then his sputum for A, B, and CB NAT were negative. And then we decided to do a bronchoscopy, and there was a lot of secretions, very dark, aspirated, collected everything, cleared everything, and sent for analysis. And the diagnosis came as mucormycosis. So one example of how diagnostic bronchoscopy helps when you are stuck with a case without a diagnosis. Similarly, endobronchial tuberculosis is very common in addition to the parenchymal tuberculosis. Sometimes it is more, sometimes it is less. Here you can see the mediastinal lymph node. It is coming from the subcarinal lymph node, what we call as the station 7. It is eroding into the bronchus, and trying to burst into the bronchus. So such type of things you can see only when you do a diagnostic bronchoscopy. Tumors is another area where diagnostic bronchoscopies can do a lot. Here is a case where a tumor is occluding an entire right main bronchus. In the olden days, we were happy just doing a little bit of brushing on top of it for fear of bleeding, a little bit of pinch of biopsy, run some saline over that and then collect some washings and then come out. But today, we use a lot of material like electric cautery, laser, cryo, and then debulk the complete tumor so that the normal anatomy is restored. Of course, once the diagnosis, histopathology comes, patient will go for appropriate chemotherapy. Here is another case where you can see a very long, elongated tumor-like structure. This was completely removed, and this patient actually had, it's a 10-year-old child who had osteosarcoma of the left leg. Patient had cough and breathlessness, and this was the metastasis in the lung, and which was coming out. So that is as far as the bronchus trachea is concerned. Whatever we pierces the bronchus and then goes into the lymph node and then collects the sample. So this is how it can done. There is a linear probe and there is a radial probe. Radial probe is like sunlight from all sides. It has an ultrasound radiation going on. You can see on the right side it's a heterogeneous node signifying that probably it is tuberculosis, and on the left side it is a very dense lymph node, homogeneous node, probably a malignant one. And once the EBUS sampling is done, nice good biopsies are done, we can get the diagnosis. What about these peripheral nodules? In the earlier days, we used to do a CT-guided fine needle aspiration cytology. So that means the needle has to pass through some part of the normal lung. So there is a chance of pneumothorax about 10 to 20%. Usually it remains like that. We don't have to really put an intercostal drainage tube. Just leave it like that. At the rate of 4% per day, the pneumothorax gradually subsides, and then we can, leave it alone. The sample size is slightly smaller, but now with the radial EBUS, the yield is better. There is no complications, there is no pneumothorax, there is no bleeding, unlike the percutaneous CT-guided FNSE. Here on the right side, you can see a little mass, and you can see a track which is coming from all the way from the bronchial system. So it is connected to a patent bronchus. This is called the CT bronchus sign. It means you can go through the bronchoscope and then get a nice, beautiful sample. You can see the radial EBUS on the left side. You can see the actual scope which is sitting inside the tumor. This is one of the new appliances called bronchoscopic thermal vapor ablation. It's nothing but heated steam, hot water steam, which you send it into the bronchial system. And this steam is supposed to damage therapeutically, supposed to change the mucosa so that it starts getting fibrosed and shrinking. So this method, we can use it for patients who are suffering from emphysema. Earlier days, we were doing what is known as a lung volume reduction surgery, where the surgeon used to take out the emphysematous part of the lung so that the normal lung can occupy that area and function well. So with this heated water vapor, what we can do is we can do the same thing. So who needs it? People who have emphysema, who have already used all the medications like long-acting muscarinic agents, long-acting beta-2 agonists, long-acting steroids, theophylline, etc., and still they're very symptomatic. Then what do? These are the patients who will benefit. So initially a CT scan is done, thin slice CT scans, and then we identify the areas of emphysema, select the lobe and the segment, and then the vapor, heated water vapor is sent, and as it goes into the bronchus, you can see that the area where it went becomes blanched, free from vascularity. So eventually it will shrink and the emphysema disappears. And where there was an emphysema, now all that you see is a little bit of fibrosis. There is an instantaneous relief for the patients, and add to this medical management, patient improve. So requires a big team to do all these things. Earlier we were doing also bronchial thermoplasty for severe asthma, because we know that it is the smooth muscle surrounding the bronchus which is causing the spasm. So why not we deactivate the smooth muscle? Why not we burn it so that the smooth muscle is not there and the bronchospasm is not there? So thermoplasty is directed towards that, and it's a therapeutic procedure for refractory asthma. The principle was systematic application of controlled radio frequency energy to the airways, and each radio frequency activation takes about 10 seconds, and the temperature can go up to 65 degrees centigrades, which will destroy the smooth muscle. But now, all over the world, people who have used it are not really very happy with the results, so it is now coming to an end and it's not being used anymore. So another very important area where a bronchoscopy can help is wherever there is stenosis of the trachea and stenosis of the bronchus, like tumors, sequelae of the tuberculosis, post-intubation tracheal stenosis, and these can produce stenosis, narrowing, and difficulty in breathing. So here, two types of stents are available. One is the metallic stents, which are used for malignant lesions. Another is the silicone stents, which are used for benign lesions. They can be deployed either with the flexible fiber optic bronchoscope or with the rigid scope. And before putting the stents, we need to take a CT scan, do a realistic reconstruction, and then find out the length of the stenosis, measure it, and then accordingly take the appropriate length of the stent and in the airways. They are very common. Nearly 3,000 in India alone, 3,000 deaths per year. You need to have a very high index of suspicion to make a diagnosis of foreign bodies. It is mostly in children, less than 15 years, especially between 1 and 3 years. What are the foreign bodies? They are usually peanuts, custard apple seeds, and then they can be mistaken for asthma. They can be mistaken for pneumonia, and plenty of antibiotics are injected to the little babies. But the truth and reality is that the child has got a foreign body which we need to make a diagnosis. Usually this triad of cough, wheezing, and decreased air entry, this triad is very diagnostic of a foreign body in the airway. As I said, there was one series which looked at these foreign bodies, nearly more than almost 13,000 cases. What they found was most of the foreign bodies were in the age group of 3 years. What were they? 81% nuts and seeds, 88% were in the bronchial tree, and 11%, only 11% were radio opaque. So if you're trying to diagnose a foreign body in the chest X-ray, you will miss them. And majority, nearly 90% of them are not seen on the radiology. And the most important investigation for making a diagnosis is an X-ray chest PA view done in an expiratory phase. When the patient expires, all the air comes out of the lungs except that part of the lung where the foreign body is there. So there the air is trapped. So you can see the trapped air only in the expiratory phase of the chest X-ray. That is very useful. This is a case which I saw nearly 10 years ago. Young girl going to the college. She came and said, she told the doctor, my scarf pin disappeared. So then the GP referred her to a gastroenterologist, thinking that the scarf pin, the girl has swallowed it. So the gastroenterologist did, So I think it's not moving. Ultrasound was done, negative. Then the upper GA scopy was done, negative. Then they forgot to take a chest X-ray. Then the patient was referred, and then when I took the chest X-ray, I could see the pin in the trachea, and it was upside down. So then something wrong. Can you move there? Didn't copy. Thank you very much.
Thank you.
In asthmatic patients, so they present only with cough, and particularly seen in younger population, young age group, adolescents, and more in females than in males, and we need to treat them with inhaled corticosteroids, and they do wonders. Treatment inhaled corticosteroids plus minus a leukotriene receptor antagonist.
Thank you. Any questions?
Request Dr. Satish Rao to...
Wonderful job, so thank you for that. And the speakers, of course, for being on time. Wonderful job. Dr. Udayala.
Dr. Rajarao, sir.
And it's my pleasure and honor to invite Dr. Ganesh. He's a leading consultant and head of the Department of Hematology.
The vast, subspecialist of medicine, I must admit, this is my first opportunity to interact with the cross-specialty legends from our city. So the topic of my presentation today is bone marrow transplantation, a revolutionary treatment for the management of hematological disorders. So what I'm going to do is I'm going to take you through through cases and how we have evolved and what revolution when we think of bone marrow transplant in the field of hematology and oncology. So again, thanks for this virtual to actual interface. It's been severe pancytopenia, hemoglobin 6, WBC 300, and platelet 10,000. And on peripheral smear, scant smear, occasional lymphocyte, and very scattered RBCs. So we did bone marrow, and you can see for a 9-year girl, this was a very empty marrow, most of it replaced by fat spaces, and because she's a girl, we also did the stress cytogenetics to rule out inherited bone marrow failures. So now the diagnosis is she has in fact very severe aplastic anemia because her neutrophil is less than 200, and on top of that we have MDR GNB, MDR E. coli on board. So how to treat this case? So this is a medical emergency, so we stabilized her, and this is the blood culture plate. You can see E. coli, and on antibiogram you can see the culture plate shows only the colistin sensitive, all other cephalosporins and carbapenems resistant. So we stabilized her, we did the HLA typing, and we did the basic transplant workup. She is the single daughter of the family. As I mentioned you earlier, it's a medical emergency. Aplastic anemia is always a medical emergency. So we proceeded because she's the single daughter and there is not much of a time to see for the suitable donor. We proceeded with emergency half-mass transplant with father as a donor. Unfortunately, you can see 35 days post-transplant, she continues to remain severely pancytopenic. We did bone marrow, and bone marrow, to our nightmare, turned out to be completely hypocellular. So this is graft rejection, again half-mass transplant. Graft rejection is one of the threat, risk as high as 10 to 15%. So what to do next? Now she is severely pancytopenic, she is transfusion dependent, she has this MDR infection. So we proceeded with second consecutive half-mass transplant, with now switching the donor from father to mother. Fortunately, she succeeded, she engrafted, and she has post-transplant a manageable graft versus host disease, infections, mostly viral infections, but which was manageable. And her last follow-up was this year, June 2022, and this is her picture recently. So, very severe aplastic anemia with MDR E. coli sepsis, it is a certified death sentence, and that's the magic of bone marrow transplant right in time. And not only one transplant, this is probably the first successful double half-mass transplant from our country. So the outline is I'm going to talk about everything needed for a clinician to know about bone marrow transplant. So who, what, where and when, and how many types of transplants, and why as a clinician you need to know about transplant. So what is hematopoietic stem cell transplant? It's a unique procedure known to cure a vast majority of hematological disorders, mostly like cancer, blood cancers, immune diseases, bone marrow failure, and metabolic disorders. So what we do to cure a diseased bone marrow, you replace the diseased bone marrow from a healthy bone marrow by way of healthy stem cells from a suitably matched donor. What will this do? This will create a new blood and immune system of donor origin, and that will persist for the rest of the life of the patient, and by this that will cure the underlying whatever condition. So this is performed almost close to 65 years since 1956, and to date there are more than 10 lakh patients who have been benefited and in fact cured with this kind of treatment. So before we think of bone marrow transplant, let us take a look back which can give us a better perspective of what is going today and what will be the future. So essentially the atomic bomb explosions in Japan in 1940s precipitated the research, and this was the first human bone marrow transplant published by the father of bone marrow transplant, Professor Donald Thomas, on 6 terminal cancer patients. And as a matter of fact, all of them died, but this was the first attempt. And you can see it's a funny editorial. If you look back, this is the most prestigious NEGM editorial on this article. And you read, I'll just read a few lines for you. In an atomic age because of the initial disappointing results, the number of transplants subsequently drastically got down. Very few people continued their efforts, and one of them was Dr. Donald Thomas. In fact, this failure with human bone marrow transplants led them to explore the transplants in animals, like these are transplanted dogs. And Professor Donald Thomas, having his stay in the farmhouse, he has a he used to take all these transplanted successful dogs at home. And at one point of time, he has 25 dogs. And most of these dogs survived 10 to 12 years, which is a normal lifespan for this dog. And this was the first dog who succeeded, allogenic transplant from its littermate. So there was a nice paper, Nobel Prize for this test dog, way back in late 60s. So going to through the pages of history is very important, particularly for students. So the first breakthrough came from the Jacobson's experiments, which he conducted. He demonstrated that the mice exposed to lethal radiation can be saved by this splenic cells infusion. And that's the logic of stem cells rescuing the destroyed bone marrow. Then came the first bone marrow transplant by Professor Donald Thomas. Discovery of first HLA antigens by Jean Dosset. He subsequently received another Nobel in the field of transplant. Then in 1960s, there was a radiation accident in Yugoslavia, and Professor George Mathé from France did transplant for 4 of the patients, and 4 of them survived. And the first, then in the same year, transplant immunology take a next step by pioneering work of Dr. Peter Medawar. And the first actual successful human bone marrow transplant happened in 1963 by Dr. Robert Kiley from Mayo Clinic, Rochester. So this was a girl that time. This was Nancy King. She has severe aplastic anemia, and it is very, to understand, the treatment was high-dose steroids, and because of the steroid, you can see her Cushingoid faces. So it was Dr. Robert Kiley's observation that this girl was accompanied by another thin sibling, and on inquiry, he proposed possibly she is her syngenic twin. So how they used to establish whether it is a similar identical twin or not? So they used to do the skin grafting from thigh of each other, and if the skin graft is retained, and that was the marker, surrogate of possible identical twin. And this was her recent photo, so you can understand, almost 60 years post-transplant, she is cured and leading a normal life. Then came 1968 modern HLA typing, and the first matched sibling transplant by the famous immunologist Robert Good at Minnesota in a boy with SCID, David and Donna. So this was the landmark paper published in NEGM for first 100 blood cancer patients with bone marrow transplant, for which Dr. Donald Thomas was felicitated with Nobel. And it is very fascinating to understand initial transplant results were very, very frustrating. Out of 100, only 16 or 18 were long-term survivors. Then subsequently, and how they used to do the transplant in this US military bunkers, the patient used to taken for radiation, and this was again an exercise taken by US Atomic Energy Commission. Needless to say, with the atomic bomb threats, this was the major drive for this transplant. So subsequently, I've just quickly run over. First, unrelated donor transplant 1973 in UK by Dr. John Hobbs, and for the Simon Bostic, who has chronic granulomatous disease. And this is his recent picture, just last year. So completely cured and leading a normal life. And this unrelated donor success led to foundation of Anthony Nolan, first international unrelated donor registry across the globe, based out of UK. So, and this 88 first umbilical cord blood transplant by Dr. Ellen Gluckman and Boxmeyer from Ellen Gluckman from France, and this was the boy completely cured and still alive. He's helping the patients and the families with the umbilical cord blood logistics. Then coming to 2000 era, so this was the first breakthrough from John Hopkins group, Leo Luznik and Efrain Fuchs, the haploidentical transplant, the reality with a high-dose cyclophosphamide. And now we have a designer graft thanks to Professor Rupert Hangritteker. I had the privilege to be trained under him for 6 months, and I will come to this novel therapy soon. It's very fascinating to understand hematopoietic stem cells, which are very real cells in the bone marrow, but they are powerful to generate complete hematopoietic system, and which can cure vast majority of not only cancerous conditions, but n number of non-malignant conditions. So I like the famous saying, eyes are useless when the mind is blind. It's very important to think in this perspective in the field of hematology. So the logic of bone marrow transplant for students for malignant conditions, malignant diseases, permit high-dose therapy and also induce these stem cells from the donor, keep on attacking the cancer cells, preventing it from coming back. Whereas for non-malignant, to restore hemostasis, hematopoiesis, and to replace defective genes. So in nutshell, how we do this, we need to think differently. So replacement of defective marrow, for example, lymphocytes, immunodeficiency disorder. And this is the picture of bubble boy David Vetter, who was the first child in the world who survived with SCID, immunodeficiency, up to 14 years of life. And that was because of this bubble care, aseptic precautions in the late 60s and 70s. And thalassemia, where erythroid cells are defective, myeloid cells are defective in various, again, immunodeficiency disorders, and like our girl, aplastic anemia, where all the 3 lines are defective. Again, for malignant indications, the rescue marrow from ablative high-dose therapy and also graft versus tumor effect, like AML, high-risk AML, ALL in pediatric population, CML, accelerated phase, lymphoma, myeloma, and pediatric neuroblastoma. And the third one is for metabolic or genetic conditions, where there is this is because of genetic defect, where mechanism of tissue damage is built up of toxic metabolites, and then this transplant, the donor histiocytes repopulate the affected organ, remove these metabolites and reverse the organ damage, and also replace the defective enzymes and genes. So why Kattappa killed Bahubali, the biggest cinema suspense of 2018, fetching highest revenues for Bahubali 2. This curiosity of inquisitiveness is a basic theme of any medico. So the more why we ask ourselves, the more wiser we become. And we have come a very long way with regard to transplant. The success rates in 70s and 80s, 60%, then 90s, initially 40%, 60%, and currently most of the benign conditions, the success rates are 90 to 95%, and for malignant indications, it's 80 to 90%. So bone marrow transplant, this is a picture in our mind. Most of us, it is not so. It is a very most advanced and a very powerful curative therapeutic modality across vast spectrum of hematological conditions. So when we think of bone marrow transplant, like as I discussed, the father of bone marrow transplant across the globe, Professor Donald Thomas, Nobel laureate. The father of hematology bone marrow transplant across India is Professor Maman Chande. I am a proud, privileged student of Dr. Maman from CMC Vellore. So common misconceptions for clinicians about bone marrow transplant. Many of us, even I'm sure many of us clinicians believe it's a major surgery like liver, kidney transplant. It's not a surgery, it's a simple stem cell transfusion just like any other blood transfusion, but it comes with a lot of intricacies, and that's why you need a dedicated transplant unit and a transplanter. Blood group matching is not at all essential. If it is blood group matching between donor and patient, well and good, but if not, we don't stop the transplant formalities. What is important is HLA gene matching. If not full, a half is enough. Many Telugu donors feel that bone marrow is going to be extracted from their body and they will have this deficit for the rest of their lives. It is not so. We just collect the stem cells just like platelet on an apheresis machine, and these get replaced in a matter of very short time. And the most important for clinicians, many of us believe bone marrow transplant is the last step in management with very dismal outcomes. It is not so. In fact, it is the only curative therapy across vast hematological spectrum with cure rate 80, and in some conditions 90% also. So the stem cell sources not only bone marrow, but from peripheral blood like I elaborated, and also sometimes umbilical cord blood. So stem cell donation is safe and very easy, and it can be done while the donor is alive. So switching gears further, this is the transplant process, different types of transplant depending upon the type of donor. Autologous, when the patient's own stem cells are used in lymphoma, myeloma, and syngeneic or allogenic when there is a donor, family member or international HLA match donor. So this can be again various types, full match, half match, and so on and so forth. When we consider different types of transplant, let us see where was India compared to the rest of the world. The first transplant in world 1956 by Donald Thomas, whereas the first transplant in India was 1984 at Tata Memorial Hospital, Mumbai by Dr. Arwani sir and his group. It was an interesting story. You can see the logistics with Mr. Sunil Dutt, the famous actor, brought all the medicines and catheters from US for this transplant, and Mr. Kirloskar, a famous businessman, provided laminar flow. So, you know, from that to today, there are more than 10 transplant centers in Hyderabad itself. The first unrelated donor transplant, as I mentioned, 73 UK, whereas first unrelated transplant in India took almost 25 years more, 2006 by Dr. Maman and his group at CMC Vellore. The first umbilical cord blood transplant in Paris in 1988, whereas the first umbilical cord blood transplant at the family member umbilical transplant at 1996 at Tata, and subsequently the pioneer work on umbilical transplant was done by Dr. Revati Raj at Apollo Hospital, Chennai. The first unrelated donor transplant happened, the haploidentical transplant happened in 1980s by Dr. Reiner and O'Reilly from MSKCC, whereas the first unrelated donor transplant, the half-match transplant was done by Dr. Suparna Chakravarti at Apollo, Kolkata in 2010. So I'm just putting this timeline and also explain where we are as Hyderabad and Telangana. So first, T-deplete, most advanced haplotransplant in 2010 and in India by 2014. So with that, I will present another case. This was a 22-year boy, CML blast crisis. He we gave him very high dose chemotherapy, just got him his disease under control, and just when we were taking him for transplant, he presented with isolated CNS relapse. And CNS is something in the brain, the transplant, the graft versus tumor effect doesn't work. And this was the patient in 2016. So we did a CNS directed therapy, and we did this most advanced TCR alpha beta CD19 deplete half match transplant, which happened in world in 2010, in India 2014, and in Hyderabad 2016. And this is the first adult patient of India for which we did a half match transplant. And this is his recent picture, completely doing well, resuming his job as an IT professional. So what we do actually in bone marrow transplant, and why we need this a separate transplant unit. By destroying the bone marrow, we make the patient severely immunocompromised, and this is the care which used to exist in the ancient 60s and 70s, and this is the modern transplant unit. So the logic is to keep the patient under aseptic, sterile environment to protect them from infections. So everything matters in the transplant unit. So there are 3 steps in bone marrow transplant. The first, to destroy the defective marrow, we do high dose conditioning chemotherapy. So it eliminates the diseased marrow and prevents the graft rejection. At the same time, donor receives these GCSF injections for 5 days to mobilize the stem cells from marrow to the blood. The second step is stem cells are collected from the donor and infused to the patient. This is called a day 0, and then there are post-transplant 2 phases, pre-engraftment and post-engraftment. Pre-engraftment in the bone marrow transplant unit when the patient's counts are very low, and post-engraftment, patient returns to the primary care physician, pediatrician, and in collaboration with hematologist continues caring for this patient. So what are the complications in post-engraftment period? So periodic follow-up is required, because even though the blood counts recover, but the immunity, B cells, C cells, takes 6 months to 1 year, and that is the time when the patient is prone for various opportunistic infections. GVHD, when just like the GV, graft versus tumor, the stem cells can attack patient's body and cause various manifestations, most notably skin, gut, and liver, acute and chronic. And the third one is organ dysfunction because of the chemotherapy. So this is very important for clinicians to monitor, follow up these patients. Again, this is a patient whom we did transplant in 2015. She recently visited with her 2-year daughter. So even after transplant for severe aplastic anemia, she conceived and became a happy mother. So donor choices, as I mentioned, in 2022, we cannot deny transplant for anybody because of lack of donors. There are 25% patients have full match family donor. For another 15 to 30%, we can found an international donor, but 40 to 75%, they don't have donor. And for them, because of the advent of the half match transplant, nobody can be denied transplant if they require it. So the advantages of haploidentical donor or half-match family donor, always available, highly motivated, and you can manipulate it to various ways. There are risks also, but this can be covered with various newer innovations. So this was first half-match transplant in 80s, as I mentioned earlier, for a immunodeficiency child, and completely cured. And this is a NEGM paper in 2014. You can see the results of half-match transplant at par with the full-match transplants. So what is new in the transplant? I'll just quickly spare another 2 minutes and before I conclude. So I mentioned you different technicians, different techniques of half-match transplant, T-deplete. We have come a long way in this also. So it's very fascinating, you know, what we do in half-match transplant. The threat is because of this half mismatch alloreactive T lymphocytes, which can be depleted by these modern gadgets and modern machines, and you selectively keep the good cells in the patient's in the stem cell product, infuse that, and get the toxicity of this mismatched product away. So NK cell, gamma delta cells, which are our good cells which protect from infections, also cancer coming back, that is retained. Alpha beta T cells, which are alloreactive T cells. You know, science is so fascinating. Immunology, the breakthroughs in immunology has led to these different things. And this was the major review article, Haplo is the new block editorial in 2014. And after that, the number of haplo transplant across the globe has hugely changed. So the complications of transplant challenges, these are the unmet needs. But because of this immune reconstitution by various techniques, the outcomes are much better in 2022. So I'll skip that. So, number of transplant in India, for a population, the requirement of transplants is roughly around 90,000, and we are just doing 2,500 transplants per year. That is not even 5% of what is required for our population. So there is a long way to go. And just last year, just before the COVID pandemic broke down, we had an opportunity to visit Peking University, Beijing, China, and it was fascinating to see one center doing almost 1,100 half-mass transplants per year. So if we desire, it can be done. And just this is the last case. Another boy, again, double half-mass transplant, and post-transplant he has a lot of complications, but because of the novel drugs, he was cured, and not only cured, despite this turbulence, he secured 80% in his 8th class. And this is another 65-year-old man with half-mass transplant.
To just summarize.
Yes, sir. Yes, sir. So we have come a long way. The outcomes are much better. There are another important slide, sir. Haploidentical transplant as a platform for organ transplant. The idea is very fascinating. You infuse half-mass donor stem cells to the patient and subsequently do organ transplant without the necessity of lifelong immunosuppression. So this is a concept upcoming, and again half-mass transplant for various autoimmune conditions. So with that, I think COVID vaccine is something which is eye-opening for us. If we desire and if we put our efforts, science can be accelerated, the scientific growth can be accelerated to any extent. A vaccine which usually takes 8 to 10 years minimum, the COVID vaccine was available to a lower middle income country like India in a span of 10 months. So anything is possible. Future is very exciting, and India being a world's fifth largest economy, we cannot get away with excuses of not adopting to this novel techniques. So we need to change our approach to offer the best chance of cure and survival for our patients. And these novel techniques have opened Pandora of opportunities. We just need to adapt to that. So to conclude, 30 seconds, sir. The revolution in bone marrow transplant: 80s first transplant, 50s first transplant, 60s breakthrough in immunology, 70s clinical BMT takes off, 80s alternative donor transplant and widening indications, 90s new stem cell sources, 2000 older patients cord blood transplant, 2010 half mass transplant, and 2020 different graft engineering, graft manipulation leading to better outcomes in the survival. So we have come a long way. So this is my last slide. So you can see the F1 race formula, the 4 tires are changed within 1.82 seconds, and this is precision medicine for all of us. So all the specialties you have heard from the morning are progressing at such a rapid pace, and in this journey I just want to make a public apology for imposing financial poverty so many families, but this was with the pure intention of relieving these patients and families of their sufferings. Thank you.
Thank you, Dr. Ganesh, for a wonderful presentation. Please join us, and if there are any questions, 1 or 2 from the audience, we can take them.
Come up, because there has been a study also recently published, and I just wanted to take your opinion. Unfortunately, I couldn't interpret it, but I probably lost my mom because of that. So I just want your opinion on that.
So that's thank you so much for that question. So like any viral infection, the same is true with any viral vaccines. So they can alter our immunology to any extent. So we see a lot of vaccine associated cytopenias, ITPs, AIHs. In the same way, vaccine associated, what vaccine induces the immune, humoral as well as cellular immunity against, protective against that pathogen. So these immunity may cross-react with the hematopoietic cells or any, for that matter, any system, and can cause various myriad of manifestations, including autoimmune cytopenias and possibly autoimmune pancytopenia or aplastic anemia. So there are various anecdotal case reports are also case series across the literature.
Last question, what would be the rough cost estimates of the bone marrow transplantation in 2022 in Hyderabad?
So again, thank you, sir. This is a difficult question, but depending upon the type of transplant, autologous transplant, roughly 8 to 10 lakhs.
full mass transplant around 15 lakhs, half mass transplant 18 to 20 lakhs. And the newer T-deplete half mass transplant, which is more safe and in fact more productive, more effective, more curative, the cost will be 5 to 8 lakhs more for the depletion of those products.
So it's very nice, Ganesh. Better in future probably the prices also will come down because the number of cases are increasing after this viral illness and all. Okay then. Now we are concluding and I request Dr. Naval Chandra and Dr. Srirang and me. It's happy to Thank you, Ganesh.
And it's my proud privilege to introduce the speaker for the next session, Dr. Girish Narayan. He has been my teacher, mentor, philosopher, and guide. He is one of the brilliant nephrologists, not only in Hyderabad, but in the country. And he is a wonderful human being, a great teacher, empathetic human being, and he is a stickler for rules. And he has taught all this, apart from nephrology, to all his students. So today I'll be chairing the session where talk is given by Girish sir, though most of the times it's reverse. He being senior is the chairperson and I'm usually the speaker. So this is a change. And welcome, sir. Looking forward to hear to you about the recent advances in nephrology.
We have gained throughout the day, and whatever is probably is not useful is probably excreted out so that we retain the most important things in our brain. So, but coming back to the topic for today, before that, certainly, I would like to pay respects to my mentor. Next slide, please. Next, it's here. Ausculted this lady. That was first clinical posting. We auscultated, heard some abnormal sound. We didn't know. Somebody said systolic murmur. Somebody couldn't. Then he said, this is pericardial rub. And that was the teaching for the day. He said, this is enough for you. Now you can go. Dr. Vijay Kumar was talking about assessing the candidate in the examination by one question. So same way Dr. SRO used to impart the important aspects of his learning through very simple and in a very, he emphasized the importance of each and every clinical sign. I fondly recollect one particular patient who was well-to-do, probably an industrialist. He had some pain, back pain. Dr. SRO, those days all of us know there was no diagnostic facilities. So he suspected dissecting aneurysm of the aorta. Those days Bombay was the only center. That man went to Bombay, came back without a diagnosis. They said it is not dissecting aneurysm. Dr. SRO was very emphatic. He said, no, this looks like it. And that industrialist went to London. He arranged for his checkup in London. And to our surprise and to our belief, that turned out to be a dissecting aneurysm. He was operated in London. That shows his clinical acumen, the importance of proper history taking, and the importance of interpreting each and every physical So these are the few instances where I can never forget what I have learned with Dr. S.R. Rao. And I was fortunate enough to get the gold medal in medicine instituted by Dr. S.R. Rao's family. And that is a prize collection in my collection. And then when I was fortunate that even the oration in his name was allotted to me in 2016. With that brief remembrance of Dr. S.R. Rao, let us see what we can learn today in the so-called recent advances in the field of nephrology. These are the continuous process, but what I could just gather about 8 or 10 points for discussion, probably I may not be able to discuss all these points together, but now we have a new method of calculation of GFR without taking race into consideration. We have various conflicting and always debated discussion about the diagnostic and prognostic markers of acute renal failure and when to start dialysis in patients with acute kidney injury. Then we have some new antigens in the glomerular diseases, especially in membranous, and always debatable, controversial newer therapies in the management of diseases like ANCA vasculitis and IgA nephropathy, which is again being discussed these days. And most important, two things which I would like to discuss today was an oral drug for the treatment of anemia in patients of chronic kidney disease. All of us know how difficult it is to treat anemia of CKD. And also, whether can we really halt or reverse the kidney damage in a patient with chronic kidney disease. So new in membranous nephropathy, all of us know that it is an immune complex mediated disease. Way back in late 50s, it was recognized that it is an immune complex mediated disease. The antigen was in the kidney itself, transfused into the other animal, produced a similar lesions in the other animal, indicating that there is a transferable factor or immune complexes which can cause renal damage or immune complex diseases. For almost 50 years, there was no new development in the identification of the antigen for membranous nephropathy, but the landmark breakthrough came in the year 2009 when a phospholipase-associated antigen was identified, and PLA2, which is now a standard being done by most of the laboratories, can be identified. So nowadays, both these drugs are still being used, also in combination, to prevent further damage to the kidney. And with this drug, now we have a new drug in our armamentarium to treat patients with kidney disease. And now so many different classes of drugs have come into the market. Different trials have been done. Extensive studies have been done to identify the action of these drugs and to look at the adverse events of these drugs in the maintenance of the kidney function, improvement of the kidney function, and the side effects associated with it. What is important to understand is these drugs certainly have a very mild effect on the control of hyperglycemia. As morning we were discussing endocrinology, because of the loss of glucose in the urine, they help in maintaining the glucose control of sugar, but it's very mild. It also helps in weight loss, but more important was that its benefit in the preservation of the renal functions. There are so many trials which have been conducted with these drugs. I will not go into the details of it, but from the point of view of our discussion, in non-diabetic kidney diseases, dapagliflozin trial has been done. Those patients who have heart failure and renal disease, the DAPA heart failure trial has shown that this particular drug is useful both in patients with heart failure and those patients with kidney failure, and it is beneficial. But there are, as like ARBs and ACE inhibitors, some observations or some restrictions have to be imposed while use of these drugs in clinical practice. The so-called sick day rules for the SGLT2 inhibitor use, those patients who have an active infection, those who are dehydrated, those who have other in the perioperative state. So in these conditions, these drugs should be temporarily withdrawn so that there is no adverse effect or side effect because of the use of these drugs. Obviously, once they were found to be very useful in patients with diabetes, the various studies have come in. It shows that even in non-diabetic patients with renal disease, these drugs have very good protective effect on the kidney. It helps in maintaining the GFR and maintenance of, so various trials have been done. So most important was the Emperor reduced trial, where they showed that treatment with dapagliflozin in patients with heart disease and with renal dysfunction It helps in controlling of the heart failure and also in maintaining the renal functions. So in this control trial, they identified almost 1,500 patients who were given either dapagliflozin or a placebo. At the end of the study, they realized that the primary endpoint of death and the preservation of renal functions, less than 50% fall in GFR, or a death, cardiovascular, or death due to end-stage renal disease. Two endpoints were looked into, and they realized that this particular drug has been helpful in altering these two endpoints and found to be very useful in the management of these patients. This graph clearly shows that compared to placebo, the use of this drug has definitely altered the natural course of the disease. It preserves the renal functions. It helps in improvement of the heart failure. And now it is approved for use in patients with renal failure and heart disease. Then we come to the so-called controversial statement. We were taught right from the beginning that when we talk about chronic kidney disease, or what we used to talk about chronic renal failure, we used to say irreversible and progressive loss of renal function. The term irreversible was so much emphasized those days that we thought that once somebody has diagnosed as chronic kidney disease, that is the end of the kidney functions for him over a period of time. But now we realize that even now, some patients, they maintain their kidney functions over a period of time. Those who have stable chronic kidney disease, some patients are able to improve or reversal of kidney functions in some of the cases. And in some cases, despite all this, they have progressive loss of kidney function and they have a progressive kidney disease. So the question is, can we identify those patients who can be helped by our drug therapy? The role of RAS blocker, role of ACE inhibitors and ARB is well known. So without discussing much about this and its role in protection of kidney disease, let us move forward and see what can be. So a bold statement, you can say, in the modern day, but certainly practical, is that patients of CKD, the GFR can be improved. There are so many articles which show that there is slight improvement, either stabilization or improvement in GFR in a period of time. This is after the so-called acute reversible factors are excluded. Still, the so-called unexplained improvement in the renal functions over a period of time. This is done by proper, obviously, everything is important from the diet, control of hypertension, and various drugs. And the drugs which are going to help in improvement of the renal functions are now being worked on. Very briefly about the role of angiotensin receptor blockers and the role of aldosterone in the progression of renal disease. Aldosterone, apart from the diuretic action on the kidney and other action, what is more important is it also promotes fibrosis in the renal tissue and the cardiac tissue. And this fibrosis is now found to be reversible with use of drugs which antagonize the action of aldosterone. So various drugs have been identified for this. There are well-marked studies where they infused in animals plain sodium chloride, then ARBs, then irbesartan, along with receptor blockers or aldosterone antagonism. They found that it reverses or prevents further fibrosis in the experimental animals. So various drugs have been identified and tried. The new drug for the discussion is the new drug finerenone, which is a non-steroidal mineralocorticoid receptor blocker, which is being clinically used now for stabilization and improvement of the renal functions. I heard that some of our cardiology colleagues are really afraid of using these drugs for the fear of hyperkalemia. But let us, as a nephrologist, we feel this drug has such a good beneficial effect on the renal function, maintenance of the blood pressure, management of edema, that mild hyperkalemia, a potassium of around 5.2, 5.3, if the patient is under close clinical observation, can still be managed with these drugs provided you have a compliant patient. Obviously, where probably a judicious use of this drug could help us, apart from maintenance of fluid balance, salt and water balance, it may help in maintaining the renal functions in patient with chronic kidney disease with a GFR of more than 20 ml. So this is one thing which probably will give us hope that some patients of chronic kidney disease will be able to maintain their renal functions or even improve the renal functions over a period of time. Another drug which I was mentioning about is, all these years we were dependent initially only on blood transfusions. Then there came the era of erythropoietin. Then there came an era of long-acting erythropoietins. Then there started newer iron injections overload, which helped us in management of anemia of CKD. And of late, we have been started using drugs. Instead of using injections, we have started using oral drugs, which are now considered to be helpful by stimulating the erythropoietin synthesis in the body itself, by gene analysis, by remodeling of the genetic things intracellularly. It promotes synthesis of erythropoietin within the cell. This HIV, hypoxic inducible factor, is now considered as a treatment for oral anemia. So this hypoxia inducible factor with propylyl 4 hydroxylase inhibitors is a new drug which has been come into the into the study now. Various experiments have been done, and now after phase 3 and phase 4, first in Japan, now in even USA and India, this drug has been used for starting treatment of anemia, both in dialysis and non-dialysis patients. So these are a long list of drugs. Newer drugs are still being added, but what is approved for use in our country probably is the last one, daprodustat, which has been approved for use in clinical practice. And some of the pharma company has been given this drug for the initial trial. Phase 3 and phase 3 trial will go on. And we may start using this drug for treatment of anemia of chronic kidney disease. A trial which was conducted with the use of this oral drug both in dialysis patient, where it was used in comparison to the injectable erythropoietin, darbepoetin. They found that this has a very good effect in the response, erythropoietin response, with no major side effects. But obviously, long-term results are still awaited to clear its safety for routine clinical use in the patients of pre-dialysis and in dialysis patients of CKD. This is what I was mentioning about the trial which has been. This is a non-inferior trial. They found that the response to the oral drug was as good as that of injectable darbepoetin. And this drug could be a new drug which will help our patients for management of anemia of chronic kidney disease. So a lot of research work is being done for this particular molecule, and hopefully we may get some better information and better drug in the management of this case. Finally, as usual, the controversial of most of the MICU, the fluid therapy, the initial choice of giving large volume of boluses of 30 ml per kg and then try to resuscitate these patients. Most of the times we realize that some of the patients land up with fluid overload and pulmonary edema, which itself becomes an indication for dialysis. So there has been relooked at the fluid therapy in these cases. Various trials have been done, how much of fluid should be given and how much fluid should be maintained for the patients of acute kidney injury, and the type of drug, the buffered solutions or the saline. The various trials now have shown there is no great advantage of using buffered solutions than as compared to normal saline in resuscitation of these patients. So once the patient is resuscitated, then the question of coming the indication for dialysis, whether to be given restricted fluid or the normal fluid intake. And we realize that in those patients who have restricted fluid strategy have equal outcome as compared to the standard therapy, and those patients should not be overloaded with lot of fluid in the hope of improving the tissue perfusion and maintaining the renal perfusion in these cases. So finally, a word about the controversy about the initiation of dialysis. Classically, there were few indications for starting the patients on dialysis, and now the controversy still exists whether an early dialysis is going to help this patient in regaining their functions, and more important, to prevent the mortality in these patients. These trials have proved that there are so many trials have been done, whether the early initiation of dialysis within the first 8 hours or 12 hours of the patient's enrollment, does it alter the natural course of the disease? Does it prevent mortality? Does it prevent complications? Then we realize that preemptive kidney replacement, dialysis replacement therapy at the early stage of acute kidney injury has not shown to be any great benefit in improving the 30 days and 90 days survival. And now it is believed that it has to be individualized. So various trials have clearly shown that it is not recommended to start the so-called early dialysis in these patients and wait for the standard indications. And then the advantage of waiting for standard indication is that in some of the patients, you will be able to avoid dialysis and dialysis-related complications in some of these cases. So depending upon the individual patient, the decision has to be taken whether the dialysis has to be done relatively early or based on standard indications. And this trial has again showed, that, which is published in 2021, this trial has shown that the start AKI dialysis, does it really alter the outcome of this patient? It's clearly shown that it doesn't make any difference as far as the outcome is concerned, and the dependence on long-term dialysis is concerned after recovery from AKI. So with these various trials which I was talking about, the final consensus is that the so-called early dialysis is not beneficial from the patient's point of view, and we can wait for the standard indications for dialysis. Because even today, when I discuss with my PGs, I always remember tell him that I was trained by a so-and-so teacher, Dr. S.R. Rao, who had shown me and impressed upon us the importance of proper history, clinical examination, and applying our knowledge for the patient's care and improving the patient. Thank you one and all for this.
He has given a masterly lecture. He has impressed upon all of us that no more should we use the term irreversible in chronic kidney disease. And he has given very important messages, more for the physicians, because the new drugs, what Sir has alluded to, are in the hands of physicians and should be in the hands of physicians, many of them, because these should be used before the GFR drops to 30, before you refer the patient to the nephrologist. So he has talked about SGLT2 in diabetes and non-diabetes, Finrenone in diabetes, as well as now emerging role in non-diabetics as well. He has also talked about anemia, Decidustat, DESI. Decidustat is our own indigenous brand by Zydus for management of anemia instead of erythropoietin. So he has touched upon all the important drugs which are valuable to the physicians. So I really thank him. And apart from that, for the nephrologists, probably we have the artificial dialyzer and xenotransplant. So I think nephrology, the last decade, has been a wonderful one for the nephrologists. Otherwise, nephrologists used to be the end stage for anything, but now it's reversible. So I'll hand over to co-chair, Dr. Vinay Shekhar sir, for his final comments.
Thank you, sir. Segregate people who are likely to be...
Sorry, there's a lot of echo, I'm not able to understand.
Sir. So you said there is reversibility of the CKD, sir.
Yeah.
Can we clinically identify people, a subset of people who can be put onto these newer drugs, or people with a stable CKD, clinically, sir?
Yeah. No, Dr. Vinay, you have raised a very important point. Basically, when any nephrologist or a clinician examines the NSAIDs for their headache or back pain without doctor's advice, and they think it's not worth mentioning. They will say that they have taken medicine, they are afraid to reveal the information to the treating doctor that they have been taking some indigenous medicines. I don't directly say that, but some Ayurvedic or Unani or those medicines So the dictum is that any patient who presents with the so-called CKD, we always look for reversible factors, and we always accelerated hypertension is one thing which importance is not given. So my usual recommendation, standard recommendation to everybody, don't think of a irreversible renal failure and
for dialysis or transplant. So that's the message of talk what Girish sir has given today, and I think we should all work as a team towards that goal.
Dr. Manisha reminds of a dictum in our student days and our teaching, that a good obstetrician is one who says when not to do a cesarean, than to take a decision to do a cesarean in all the cases. So I'll put it. Yes,
Thank you.
Thank you, everybody.
Thank you, sir, for a wonderful talk. Request the chairpersons to present a memento to Dr. Girish Narayan, sir, for a wonderful disposition or new advances in nephrology. Request Dr. Raja.
And Dr. Raja Rao, on behalf of API, also to please come on the stage and take a seat. And first I will ask Amlesh and maybe Sunil to say some remarks on behalf of Dr. S.R. Rao family. And then I'll ask Dr. Srirang and Dr. Raja Rao to give some closing remarks on behalf of the API Executive Committee.
For organizing this momentous event and bringing in so many distinguished speakers, and the whole day was really remarkable commendation of our father's accomplishments, and still remembering him almost 31 years after he passed away. That's quite a for sure. I also want to thank OGKMA in the US, the Alumni Association, for Osmania Gandhi and Kakatiya for propagating this information about this event, and also arranging the fundraising for this event. And I also want to thank Dr. Srinath Reddy for accepting this Oration Award. And he gave such an excellent speech this morning, and I'm sure everybody enjoyed it. Now, on this momentous occasion, on behalf of Dr. S.R. Rao's family, we would like to make an announcement that we're going to create a Dr. S.R. Rao Scholarship for Medical Education, which will be a merit-based award for students, and by funding fully their tuition throughout their medical education, undergraduate medical education here. This is, I believe we had a conversation with the team, the principal at Osmania Medical College a few days ago, and they said that there's only one other kind of award, such an award. We want to make this award in Osmania Medical College, and if we have raised enough funds, then we can even extend it to the other two medical colleges in the Telangana state. This is a kind of a commemoration for our father, who, as you heard this morning from Satish, that throughout his career, academic career, he excelled in almost every field and every subject, despite the financial hurdles that he had. So we want to carry on the tradition. We want to be able to give this award to a deserving student. Just want to switch gears a little bit. You heard Dr. S.R. Rao's contribution to medical care in Andhra Pradesh. Let me give you a slightly different view. I know Satish gave some of the points about who my father was as a person. As you all know, he was definitely a very accomplished academic and several career enhanced achievements. He was also a patriarch for the whole family, and he provided stability, he provided guidance, and mature advice to not just our family members, but also several people outside the family who came and sought advice. We had a stream of visitors, both family members, common people, as well as very distinguished national leaders who have come to our house, and we have had the opportunity to meet some of them and grow with them. And that was something that was possible because of his magnetic personality, that he could attract such a wide variety of people, from renowned artists, renowned authors, beyond all the top medical people from judicial systems, or even the top politicians. On a personal side, he was a very devout Hindu. He practiced worshipping Lord Venkateshwara at his abode many times in a year. He would make trips to Tirupati, and we enjoyed that, and through that, most of our family is still continuing the tradition. Above all, he had been an inspiration for most of our family in trying to achieve the best that we possibly can. And because he is from the medical field, naturally, it was a natural extension that a lot of the people ended up in the field of medicine. By the last count that I made, I would say that his father was also started in the field of medicine, as Satish mentioned. In the 5 generations, we had 27 physicians that many of them were inspired by him, and who are continuing to follow this tradition of medical, pursuing science and medicine in 2 continents primarily, and mostly in the United States and in India. So that's quite a remarkable achievement for him as a patriarch of the family, and being a big supporter for medical education. Now, apart from being ambidextrous, which I think was mentioned earlier as well, one quality that he had was an impeccable memory. It's amazing that he could remember almost anything. We had occasions when, this is almost like 35 years or 40 years after he had actually witnessed a cricket match, and he could tell by the number of overs who scored what runs, and in almost in exact detail as the match had transpired. And it's a really amazing memory that he had. One of his passions was poetry, as Satish mentioned as well. I still remember that he had an habit of waking up early in the morning to catch up on newspapers. So he would read the newspaper. That's probably the best calm time that he had to be able to catch up on the worldly affairs. He used to read the Hindu quite often. And he woke me up one morning at 5:30 and to point this fantastic quote from one of his favorite poets. And that kind of inspired me to learn a lot more about poetry as well. And many years later, when I was living in the US, he would come visit us, and he would have friends around the United States. As you know, US is a very big country, and we would drive for long distances. And we really enjoyed reciting poetry, which was a common passion between me and my father, from some of the best poets, Tennyson, Shakespeare, and so on. So in conclusion, I just want to leave you with one of the lines that I told you earlier about finding in the newspaper, which I want to bring it up now because it is appropriate. It's like an advice to our next generation. And I quote, "The heights by great men, reached and kept, were not attained by sudden flight, but they, while their companions slept, were toiling upward in the night. Standing on what too long we bore, with shoulders bent and downcast eyes, we may discern, unseen before, a path to higher destinies, nor deem the irrevocable past as wholly wasted, wholly vain, if, rising on its wrecks at last, to something nobler we attain. Unquote, and thank you very much for your patience. And I'll invite Sunil. You want to say something?
Personal experience that I had with my dad for my own treatment. I was doing my engineering in Bangalore, and it was the first year, and I just started, and within a month, I developed a chronic cough during the night time. And while I was just sitting, it used to come and keep pressing my throat like crazy. I didn't know what was going on, so I just called my dad and told him that this is what is happening. And he said, how long this has been going on? And I said, it was just a couple days. So he said, catch the first mode of transport, get to Hyderabad. I said, all right. Next day, the earliest I could do was catch a bus. At that time, that was very convenient to me. Caught a bus, got home. I think it was like 6 o'clock in the morning. My dad, as all of you know, is a very early riser. He usually does his exercise. I said, oh, good, come in. And he said, go lie down on the bed. And we have upstairs where he keeps circling around for his exercise. So I was lying down, and again the same thing happened. Something was choking in my throat, and it was as if somebody was killing me. And he asked me to sit up and gave me a glass of water. And then something stabilized a little bit, but again I was feeling the same symptom. He went down, he came back with a small bottle, I don't know what it was. He said, just give me like 2 drops of it, and he said, lie down again. I lie down, and that's it. I mean, it was gone. The next day, there was no symptom at all. Then I asked Dad, what's going on? He said, it's a peculiar kind of whooping cough, and it's very common in where you are in Bangalore. And he gave that, he said, continue for 3 days. And after 3 days, he said, just go back. So I knew what kind of a physician and a clinician my dad was, my personal experience. That's what I wanted to share. Thank you. That's it.
Maybe Dr. Rajarao to give this memento to Mr.
And my API members, teachers, and all the delegates. It's a very pleasureful and happy moment for me to be here, because I heard so much about S.R. Rao sir, but I am too young to be his student. I joined medicine in 1987 after a decade when S.R. Rao sir has retired. But our teachers, S.R. Rao sir, as just now Girish Narayan sir and Dr. Vijay Kumar shared their experiences with S.R. Rao sir. So he's such a great teacher and a great physician, and I appreciate Dr. Satish Rao really. Since almost 1 year he is struggling for this seminar to happen. Initially, actually I was busy with being a hospital institutional head. I was very busy. Even then, he's tried so many calls and messages and through mails. And I'm sorry, sir, most of the times I have not responded to you. And on my behalf, Srirang has taken everything onto his shoulder on behalf of API. Thank you, Srirang. And with the constant and tireless efforts, Satish Rao sir has made it a beautiful seminar and beautiful and very excellent teachers. And thank you, sir. Actually, it's beneficial to our API Hyderabad chapter and all our fellow colleagues. Actually, sir is a founding member of the API Hyderabad chapter. So it's very nice to be here in this evening, sir. And thank you very much. Thank you all.
Freemasonry Lodge 140th Foundation Day, Golden Jubilee of our API Hyderabad chapter, and the Centennial celebration of Dr. S.R. Rao sir. I think I must truly salute the passion and the perseverance in pursuit of that phenomenal perfection which Dr. Satish Rao sir has been following. And it's been a pleasure and a great learning experience as to how to go about organizing things, planning them to perfection, and then making sure even the minutest thing is going on in order. I am truly thankful to the entire family of Dr. S.R. Rao sir for being here today and then single-handedly conducting this wonderful program with small contributions from our side. I would also like to thank our entire executive committee of the API Hyderabad chapter for their support and cooperation in doing that. The generation of speakers we have heard are probably a different era where you may not find them a decade after, because they are truly seen medicine from various perspectives, and what we find from their experience is totally invaluable. You may have a lot of gadgets in your hand, you may have too much information which is available on the net, but you will not find the experience and the way to interpret that information which you get from these legends which we have heard today. So it's been a real pleasure for me and a learning experience per se to be part of this wonderful program, and I'm thankful to all members who attended, and those who did not attend this program for various reasons. I'm sure they've really missed a wonderful program, because we've had, as we will recap in a short while from now, speakers probably the best in the world, not only in Hyderabad, but best in the world, speaking to you on the cutting edge technologies and the innovations happening today in 2022, and then they've really missed something truly remarkable. I thank all of you once again for being here and then supporting this event. Thank you.
Maybe one important pearl from each lecture, if we can. So I'm going to have Dr. Srirang Abkari to very briefly recap of the morning session, and then it'll be followed by Dr. Nagaraj Rao, who will recap what we learned in the afternoon session. So, Srirang.
We had the endocrinology session in the morning, wherein Dr. Rakesh dealt with the science of obesity, because there are so many mechanisms we are not yet understood regarding obesity, the newer drugs in a difficult to treat problem, and then how to go about targeting obesity, to similarly looking same BMI individuals may be having different risk based on their visceral fat. So that is what we learnt about differences in obesity and how to treat them. Dr. Neelaveni again helped us understand precision medicine, wherein diabetes, which we know as type 1 and type 2 broadly, are not what we imagined them to be, but there are several subsets including LADA and then the monogenic types, where if we understand them both by phenotypic and genotypic variations, we can probably have a targeted therapy much to their body habitus and genetic makeup, so that that can be benefited. So she talked about precision medicine. Moving on to gastroenterology, we had a poetic rendition of gastrointestinal endoscopy by none other than Dr. Nageshwar Reddy, who all of us have been hearing through the years, and every time his talk is actually a verse in a poetry. And then we also learned about the newer techniques of endoscopy, treating diabetes maybe through duodenal mucosal ablation, which was a new thing as diabetes is rapidly evolving, and then having those endoscopic myotomies which are done for various diseases, how endoscopes evolved to the latest innovation of disposable endoscopes. He took us through a journey of endoscopy, and it was phenomenal as usual to listen to him. Then the World Authority on Neurogastrointestinal Motility, none other than Dr. Satish Rao. It was phenomenal how experiments in lab are translated into clinical practice, and then we saw so many experiments done by him and publishing in papers in various peer-reviewed journals and actually finding solutions for problems which we think are actually psychological sometimes, but he has shown us that different thresholds because of different chemicals may alter the perception of pain or other motility, and that video which he showed where sudden bloating occurred due to the gas formation, which we would have otherwise neglected it to be something crazy, but he said that respect the patient's symptom, try and understand what it is, and then if you are not able to answer, try and think over it, because respecting patient symptoms is of utmost importance. All the innovations in gastrointestinal motility were very well elucidated by him, and we look forward to applying them in our clinical practice. Moving on to cardiology, Dr. Shantaram sir dwelt about the medical education past and present. Being a wonderful teacher himself, the Dean of Nizam's Institute of Medical Sciences, I personally had a privilege of working under him, and he is one person who's known to create adverse circumstances into your advantage, and then final goal of our medical education being not earning money or fame, but the end user, that is a poor patient, should be benefited. So these are even more relevant today in this era where we sometimes forget what a role of a doctor is truly. And then sir has very nicely with his experience elucidated how important it is to focus on the patient care and then dedicate our life through relentless, sincere service. Finally, Dr. Dayasakar Rao sir explained us translating new evidence in cardiology into clinical practice, wherein highlighted the newer innovations, including various new drugs in cardiology, where we moved from just treating a particular symptom to actually having mortality benefits, be it the SGLT2 inhibitors, be it advances in coronary angiography, including the IVUS, where you can calculate the plaque burden, you can know how well your stent is placed by the optical coherence tomography, calculating the fractional flow reserve to know whether a lesion is really clinically significant, using the stress testing and the cardiac MR to know the functional status of the myocardium, what is stunned myocardium, what can be actually revived. And he himself is an excellent clinician who, with his experience, told how to interpret newer technologies in applying for the patient benefit. Finally, in the morning session, we had the prestigious Dr. S.R. Rao sir Memorial Oration, delivered by none other than Dr. Srinath Reddy, the President of Public Health Foundation of India, who explained, as clinicians, sometimes we are focused only on individual care, but how important public health is, how public health initiatives mean to a country, and how that is also important for improving the economy, both in terms of the vertical and the horizontal application of public health measures, and how climate change and other things are impacting our diseases. And then he also mentioned about the impact of COVID. He himself has done great work in COVID lineages, virus lineages, and it was really a pleasure to listen to him deliver this landmark oration on the 100th year. So these were just a brief recap of what we went through in the morning for those who have missed it, and as a revision for us to recapitulate the wonderful talks we heard. I thank you for this opportunity and request Dr. Nagaraj Rao sir to give a brief recap of the afternoon session.